Commissioner, you may now begin.
Good morning, everyone. I'd like to call to order this meeting of the Public Health Council on August 13th, 2025. My name is Dr. Robbie Goldstein, Commissioner of the Massachusetts Department of Public Health. I want to thank you all for joining today's proceedings and to remind you that this is a public meeting and it's being recorded. Before we move into our agenda, I want to take a moment to acknowledge our colleagues at CDC, especially those based in the Atlanta offices, who several days ago endured a frightening event when a gunman shot repeatedly into their building. I'm sure those who work there are still struggling to come to grips with this horrific experience. I know that I am. This shooting has upset many in the greater public health community. I spent 2 years at CDC, and for those of us who have walked that campus or worked alongside its dedicated staff, the images of bullet holes and shattered glass at a place devoted to advancing health and safety are deeply disturbing and deeply personal. I was also heartbroken that David Rose, a 33-year-old police officer, a father, a husband, and a son who was a native of Boston, lost his life in this senseless violence. Our hearts go out to his family, friends, and colleagues. According to reports, the shooter blamed the COVID-19 vaccine for his mental health struggles. That's a stark reminder of the dangers fueled by rampant misinformation and disinformation. Such falsehoods are not harmless. They cost lives, they erode trust, they create an environment in which public health professionals are threatened simply for doing their jobs. The past years have been exhausting for those who work in public health. Yet every day, the remarkable staff here at DPH, like their public health counterparts across the country, in blue states and red states, continue to show up to save lives, to strengthen communities, and to work toward a healthier future for all. We do this work together in solidarity because we know it matters. My hope is that this tragedy can serve as a rallying point for defending science, standing against the politicization of health, and for protecting and respecting all those who have dedicated their lives to the well-being of others. August is National Immunization Awareness Month, and it is only fitting that our agenda today is packed with vaccine-related topics. We'll hear later in the meeting about COVID and flu vaccination among healthcare personnel in the state, and we'll also dig into what I expect will be a spirited discussion about the state of vaccination in our country, the science, the skepticism, and the stakes. But I want to start today's meeting with something that is not a debate. It's a fact. Vaccines are the greatest achievement in the history of public health. Full stop. They have saved more lives than any other medical intervention, more than 154 million people in the past 50 years. That is 6 lives every minute. Vaccines have eradicated smallpox, nearly eliminated polio, and slashed deaths from measles, diphtheria, tetanus, pertussis, influenza, COVID, and more. Vaccines embody science at its best and public health at its most powerful. So why are vaccines under attack? Why are once eliminated diseases reemerging, vaccination rates falling, and public trust in vaccines and in the science behind them eroding? And why is the federal government retreating from investments in mRNA vaccines, the very technology that pulled us out of COVID's darkest days? These are not rhetorical questions, they're urgent challenges, and Massachusetts is ready to meet them with clarity, conviction, and action. Governor Maura Healey recently proposed giving the Department of Public Health greater authority in setting science-based vaccine recommendations for our state. This proactive step would safeguard vaccine access should the federal government fail to uphold its responsibility to use evidence, data, and expertise to guide vaccine policy. This plan is a response to the troubling shakeup by HHS Secretary Robert F. Kennedy Jr., who dismantled the Advisory Committee on Immunization Practices and appointed members who lack vaccine expertise, including some who have spread misinformation. Handing vaccine policy over to a compromised federal process risks undoing decades of hard-won progress. and it puts lives at risk. That's why Massachusetts is building a state vaccine advisory infrastructure that's rooted in science, and why we're developing the systems and processes needed to stand up a statewide and state-run vaccine program quickly if needed. Our state has faced difficult moments like this before, and each time we have answered with leadership grounded in science. In the early 1700s, Boston minister Cotton Mather listened to the lived experience of an enslaved man, Onesimus, and who described the African practice of variolation, intentional exposure to smallpox, producing milder illness and lasting immunity. As a deadly outbreak swept through Boston in 1721, Mather, despite backlash, championed this controversial approach, helping to establish efficacy and greater acceptance of inoculation. In 1764, John Adams, a Boston lawyer who 3 decades later would become the nation's second president, underwent inoculation. His wife Abigail and their children were inoculated in 1776. Their public embrace of the practice helped normalize it, showing the power of trusted leaders to change minds. In 1800, 4 years after Edward Jenner introduced smallpox vaccination in England, Massachusetts physician Dr. Benjamin Waterhouse became the first in the United States to administer the vaccine, starting with his own son and other family members. Dr. Waterhouse conducted studies demonstrating the vaccine's effectiveness, and his work helped persuade the Massachusetts legislature to mandate smallpox vaccination in 1809, the first such law in the nation. In 1855, Massachusetts was the first state to require vaccination for public school attendance. Those laws were tested in 1905 in the U.S. Supreme Court case Jacobson v. Massachusetts. The court upheld the state's authority to enact laws that protect public health, safety, and welfare, setting a precedent that continues to guide vaccine policy today. Since then, Massachusetts institutions and researchers have continued to drive vaccine innovation, discovery, and delivery. During COVID, our Vaccine Equity Initiative brought vaccines directly into communities, partnered with trusted messengers, and pushed back against disinformation, recognizing that vaccine access is about far more than logistics. It's about justice. This moment demands that same kind of clarity and courage. We cannot be passive in the face of politicized science. We cannot retreat from innovation, and we cannot forget who is most at risk when trust erodes: children, older adults, people who are immunocompromised, and historically marginalized communities. Later in this meeting, we'll host a vaccine roundtable, during which we'll hear from a panel of experts who will discuss where we stand, the challenges we face, and the path forward. I look forward to this important conversation at a time when the stakes are high, the need is urgent, and the truth is clear. Massachusetts will not shy away from doing what is hard when it is also right. Protecting health is not optional. It's a covenant we make with the people of this Commonwealth, and we intend to uphold that promise. The actions we take now not only continue a 300-year legacy of vaccine leadership, they honor it. Last month, we were thrilled to be featured in a new issue brief from the Pew Charitable Trusts. The brief, Massachusetts Harnesses Data from Multiple Agencies to Improve Public Health, highlights our public health data warehouse. Holding up the department's work as a model for other states to follow, the brief explores how the public health data warehouse enables collaborative sharing and analysis of health data to gain a more holistic understanding of pressing public health issues, in turn helping leaders to better protect communities and improve health outcomes. The dedication and skills of our data science, research, and epidemiology team in the Office of Population Health have made the data warehouse a shining example of the power of data to inform action. Also last month, the department announced the first confirmed case of West Nile virus in an animal this year. A goat was exposed to West Nile in Lunenburg in Worcester County. The towns of Lunenburg, Leominster, Shirley, and Fitchburg were raised to a moderate risk level for West Nile. West Nile virus is usually transmitted to susceptible animals and humans through the bite of an infected mosquito. The first evidence of West Nile virus in mosquitoes in 2025 was announced on June 17th, and 160 positive mosquito samples identified so far this year. There has been one West Nile virus infected goat identified this year. In addition, last month, the department also identified Eastern equine encephalitis, or triple E virus, in mosquitoes in Massachusetts. Triple E was first found in mosquitoes in Hampshire County on July 21st. You can keep track of all positive results and risk levels by checking the arbovirus update page on mass.gov. Triple E is a rare but serious and potentially fatal disease that can affect people of all ages. It's generally spread to humans through the bite of an infected mosquito. There were 4 human cases of Triple E in Massachusetts in 2024 with 1 death. There were also 4 Triple E infected horse cases last year. No human or animal cases of Triple E have been detected so far this year. When Triple E is found in mosquitoes at this point in the season, the risk may increase throughout the rest of the summer. We rely on our mosquito surveillance program to monitor for the presence of the virus to inform people when and where the risk is occurring. Elevated temperatures combined with high humidity increase mosquito activity. We want to continue to remind people that there are easy ways to prevent mosquitoes from biting you, like using mosquito repellent when you're outdoors and being mindful of peak mosquito activity hours. The hours from dusk to dawn are peak biting times for many mosquitoes. People should consider rescheduling outdoor activities that occur during the evening or early morning in areas of high risk. Last week, Governor Healy signed an act strengthening healthcare protections in the Commonwealth, which updates and strengthens our SHIELD law. The state's SHIELD law was first passed in 2022 in response to the Supreme Court's Dobbs decision. It's in place to protect providers who deliver reproductive care, including abortion, and gender-affirming care. The updated SHIELD law includes a number of important additional protections. As federal and national policy shifts continue to threaten Massachusetts' ability to provide health care, we must remain nimble and constantly evolve our response to these threats. As Governor Healy said in signing the new SHIELD law, no one is going to prevent the people of Massachusetts from getting the health care they need. Some of the principal updates to the SHIELD law include protections for families by codifying into law that accessing gender-affirming care for minors cannot be used as justification for abuse and neglect charges. It expands protection for prosecution and other liability to more types of providers across the continuum of care. It improves patient privacy, limiting the release of personal data and allowing prescription labels to show only the name of the practice rather than a specific provider. And it codifies into law access to medically necessary emergency abortions. We're grateful to our partners in the governor's office, the attorney general's office, and the state legislature, all of whom worked hand in hand to pass these important protections. Everyone understood the urgency of this moment. As House Chairman of the Joint Committee on the Judiciary, Representative Mike Day said, "We stand united in affirming that we will not allow radical prosecutors or politicians in other states to exploit legally protected healthcare decisions made here in the Commonwealth for their own political gain." On behalf of the Department of Public Health, we're grateful to work within an administration and a network of officials, advocates, providers, and patients who share our resolve that no matter what changes or threats come from the federal government or other states, Massachusetts' commitment to best in the nation protections for those seeking appropriate and necessary health care will not waver. The federal policy landscape is shifting constantly, sometimes from one day to the next. Such whiplash means DPH staff spend time chasing the latest guidance, assessing impacts, and recalibrating plans, only to find out that the rules have changed again. It's disruptive, and it diverts energy from the hands-on public health work that changes lives in the communities we serve. From the legal issues surrounding the freeze on COVID-19 associated funding, to restrictions regarding who may qualify for public health benefits, to new federal policies that undermine proven harm reduction and housing-first strategies for people who use drugs. We are working collaboratively with the Attorney General and across the executive branch to maintain critical public health services in the face of mounting federal barriers. And it's not just state government feeling this volatility. Communities, healthcare providers, colleges, law firms, and businesses across the state are impacted. Funds appropriated and promised to community organizations are being held by the federal government and not making their way to our state. Federal contracts with Massachusetts-based life sciences companies are being abruptly canceled, destabilizing operations, threatening jobs, and weakening our ability to respond to future public health emergencies. One bright spot amid this dismal news is the release of a recent Senate budget proposal that rejects the Trump administration's suggested deep cuts and instead fully funds health and human services, including the Centers for Disease Control and Prevention. The road to a signed federal budget will be long and unpredictable, but it's promising to see a federal budget proposal that values and invests in the nation's public health infrastructure. Despite the uncertainty, confusion, and the noise out of Washington, the department remains committed to anchoring our work in science, data, equity, and humanity, no matter how turbulent the landscape becomes. And with that, I will pause and ask if there are any questions or comments before we proceed. Go ahead, Mary.
Commissioner, I know I represent all of the council members and just expressing our appreciation to the DPH staff. They're fabulous. The presentations are great. The commitment's outstanding. And we too acknowledge their work. And we just want to express that today.
Thank you, Mary. I'll say thank you on behalf of 3,200 people. Stuart, can we go to you?
Thanks. Yeah, I certainly want to echo Mary's admiration and support for DPH and its staff. I was wondering how the SHIELD law does or doesn't address telehealth. I think we're all engaged with telehealth now. We know we're being asked to whether we're in Massachusetts at the time. So I didn't know if the issue was moot because insurance isn't being used, so it doesn't matter so much, or if there's any other provisions for, since the SHIELD law is trying to protect providers who may be prescribing out of state. I was just curious if you knew about that.
I'm going to attempt an answer, but I might phone a friend to Beth because I think she knows the SHIELD law much better than I do. But I think, the SHIELD law talks about the delivery of care and the protections, the privacy around care. Telehealth is one way in which we deliver care. Much of the telehealth regulation does revolve around insurance reimbursement. So there are pieces of that insurance reimbursement that are not part of the SHIELD law, but the protections that exist for providers within the SHIELD law that protect the information that they're documenting in a chart, the information that is shared with other providers, the information that may be on a prescription bottle, all of those protections apply whether the care is being delivered in person or being delivered through a telehealth platform. I'll pause to see if Beth has anything to add to that.
Nope, I think you said it well.
Thank you.
Any other questions or comments from members? Not seeing any. I'm going to move us on to the rest of our agenda. And as always, the first item is to ask members to vote to accept the minutes from our prior meeting on August 13th, 2025. So I'll ask, does anyone have any changes to the minutes? No changes.
Commissioner, I would make a motion to approve the minutes. I did review them in depth.
Thank you, Mary. You caught me right before I was going to ask the question. Does anyone want to second that motion?
Second.
Thank you, Robert. And now we will go through the roll call. Craig Andre.
Yes.
Dr. Archer.
Yes.
Lisette Blondet. Kathleen Carey.
Yes.
Emily Cooper. Robert Engel.
Yes.
Marcia Hams. Stuart Landers.
Yes.
Tom Mackey.
Yes.
Mary Moscato,
Yes.
Dr. Stinson,
Yes.
Dr. Subaraman,
Abstain.
Dr. Voltoro, and Arya Zayas.
Yes.
Thank you all. I'll vote yes as well. And with that, the minutes are approved. So I'd now like to invite Dennis Renaud, Director of the Determination of Need Program, to review the staff recommendation for Everest Hospital LLC's request for a transfer of ownership. And he is joined by Jacqueline Gagne, Chief Deputy General Counsel. And as always, we have representatives from the applicant who are available to respond to your questions after all remarks are completed. So I will pass it to you, Dennis.
Thank you, Commissioner. Members of the Public Health Council, I will present for your consideration a transfer of ownership application from Everest Hospital LLC. I will start my presentation with details of the proposed project, followed by an analysis of the application. Next slide, please. Everest Hospital LLC is a newly formed entity consisting of 3 partners. The individual partners comprising this entity possess expertise in long-term care. One partner is a healthcare practitioner and has more than 20 years of experience as an owner of skilled nursing facilities. The other partners are experiencing nursing home administrators operating multiple post-acute facilities, including skilled nursing, assisted living, and independent living facilities, and are well-versed in the types of services and needs that apply to each setting. Next slide, please. Vibra Hospital of Western Massachusetts, the Central Campus, is a 47-bed long-term care hospital referred to as an LTAC, is located in Leicester, Massachusetts, and has been in operation since September 1, 2013. The hospital is part of Vibra Healthcare 2 LLC, whose subsidiaries operate 4 LTACs, one located in California, one in Idaho, and 2 in North Dakota. Next slide, please. The total value of the proposed transfer of ownership is $14,928,424. There were no written comments on the application, nor were there any 10 taxpayer groups. Next slide, please. I will provide an overview of the proposed project. The applicant will acquire the Vibra Hospital, including all real property on which the facility is located and property associated with operating the hospital. As part of the same transaction, the applicant will also acquire the Meadows of Central Massachusetts, a skilled nursing facility located at the same address as the hospital and currently licensed by Vibra. The DON regulations do not include transfer of ownership applications for SNFs. Therefore, the concurrent purchase of the Meadows on the same property as the LTAC is not under the purview of DON regulations. Accordingly, the DON program's evaluation of the transfer of ownership application was limited in scope to the LTAC. However, where appropriate and necessary to inform the required analysis of the transfer of ownership application, the DON program evaluated the affiliation between the SNF and the LTAC, as well as the overall business transaction between Everest Hospital LLC and Vibra. The applicant has entered into 2 agreements with the Vibra Hospital of Western Massachusetts, the current licensee of the hospital. The first agreement is the contract of sale, under which the applicant will acquire the real property associated with the hospital. The second agreement is the operations transfer agreement, by which the hospital operations would transfer to the applicant after receipt of certain regulatory approvals and simultaneous with closing under the sales agreement. The applicant asserts that the proposed project will provide residents of Central and Western Massachusetts with continued access to long-term hospital services, allowing the acute care hospitals in the region to discharge patients to clinically appropriate levels of care and utilize acute care beds for more acute care needs. Next slide, please. The purpose and objective of the DON program and the regulations thereunder is to encourage competition and the development of innovative health delivery methods and population health strategies within the healthcare delivery system to ensure that resources will be made reasonably and equitably available to every person within the Commonwealth at the lowest reasonable aggregate cost while improving the health outcomes of the public. As part of a DON application, an applicant provides data and information to support the requirements of each factor. The DON program then analyzes each factor to ensure the applicant meets all requirements. As I go through the next slides, I will cover the key requirements of each factor and the corresponding analysis from the application. There are 6 factors that constitute a DON application, and they are as follows. Factor 1, patient need, public health value, and operational objectives. Factor 2, health priorities. Factor 3, compliance. Factor 4, financial feasibility and reasonableness of expenditures and costs. Factor 5, relative merit. And Factor 6, community health initiatives. Next slide, please. In Factor 1, the applicant must demonstrate the project will positively impact 3 areas. 1, patient panel need. 2, public health value. 3, operational objectives. Next slide, please. The applicant attributes need for the proposed transfer of ownership to the following. 1, need to maintain access to LTAC services. 2, need to increase access to LTAC services for the patient panel. And 3, need to assist with throughput issues in acute care hospitals. I will cover each of these points over the next several slides. Next slide, please. Regarding the need to maintain access to LTAC services, the applicant requested to package the LTAC and SNF into one sale in the interest of preserving continuity of care between the 2 facilities. As a result of the proposed project, Hometown 111 Real Estate LLC, which shares the same partners as Everest Hospital LLC, will own the real property which houses the hospital and SNF. This will remove the current real estate owner and bring both the hospital and the real estate under the control of the principals of Everest Hospital LLC. By removing the sale-leaseback structure in favor of an operator-owned real estate structure, the applicant aims to remove the financial uncertainty that is often associated with real estate investment trusts and bring long-term financial stability to the hospital. The applicant anticipates that this financial stability will enable the applicant to pursue opportunities to improve patient access and delivery of care as described in detail in Factor 1B. Next slide, please. In terms of the need to increase LTAC services for the patient panel, the hospital is currently operating at 50% capacity due to workforce shortages. In addition to the hospital's lower capacity, the closure of Vibra Hospital of Western Massachusetts in Springfield in 2023, along with the closure of a number of regional skilled nursing facilities in recent years, has widened already existing gaps in patients' access to post-acute services. Increasing patient access to the hospital through the proposed project will allow more of the patient panel to receive the appropriate level of care in a setting designed to provide that care, while also helping acute care hospitals to open beds. Next slide, please. In terms of point 3 of the need argument, the need to assist with throughput issues in acute care hospitals, the applicant referenced a December 2024 throughput survey report from the Massachusetts Health and Hospital Association, which revealed that 14.7% of all reported patients across 38 acute care hospitals in Massachusetts awaited discharge to an LTAC or inpatient rehabilitation facility. Of those patients awaiting discharge to an LTAC or inpatient rehabilitation facility, 23% were waiting for more than 30 days. The applicant asserts that this backlog delays patients from reaching their appropriate care settings in a timely fashion and forces providers to provide levels of care inappropriate to their setting. For LTAC patients with comorbidities and medically complex post-acute care needs that require specialized treatment, the impact of this backlog is particularly serious and underscores the importance of LTACs to the care continuum. Next slide, please. The applicant states that it anticipates the proposed transfer of ownership will contribute to the public health value. Once patients are discharged from LTACs, the applicant references evidence that shows improved outcomes for those who received ventilated weaning in the LTAC setting. Studies also show that patients with complex medical illnesses, which do not require ventilation, also benefit from LTAC services. The proposed project supports access to clinically appropriate care settings for patients with chronic long-term care needs. The applicant plans to improve health outcomes and quality of life by implementing standardized clinical practices, disease-specific programs, and best practices. To assess the impact of the proposed project, the applicant proposed metrics as well as metric projections for quality indicators that will measure the impact of the proposed project. The measures will include clinical, quality, and patient satisfaction. I will cover the outcome measures later in the presentation. Next slide, please. In terms of public health value and health equity, the applicant plans to use the initial year after the closing of the proposed transaction to form community partnerships and educate itself about the community's health needs so it can promote health equity specific to its locality. Since the hospital is located in an area with limited public transportation access, the applicant plans to further explore and implement transportation services programs for eligible patients and their families with access challenges. Next slide, please. In terms of efficiency, continuity of care, and care coordination, the applicant cites that the following proposed steps. 1. Communication with other providers. At admission and upon request, the hospital notifies the patient's primary care provider. The patient's attending physician at the hospital will communicate with the patient's primary care provider throughout the patient's stay as needed. 2. Coordination with the on-site SNF. The hospital's case management and clinical personnel communicate regularly with the on-site SNF to promote a cohesive transfer of patients between the facilities as appropriate for each patient's individual needs. 3. Improved intake system. The hospital and Vibra Hospital of Southeastern Massachusetts currently have a centralized referral intake system and other shared back office resources that serve both facilities. The two facilities are more than 75 miles from each other, and although the hospital takes referrals from throughout the Commonwealth, the majority come from regional acute care hospitals, resulting in the two facilities primarily serving different acute care partners. The applicant anticipates uncoupling these systems to create a new referral intake process that is specific to the hospital that will positively impact patient access in central and western Massachusetts, helping with throughput. Next slide, please. Factor 2 covers health priorities. The expectation is that, using objective data, applicants will address how the proposed project meaningfully contributes to Commonwealth cost containment goals, improve public health outcomes, and delivery system transformation. Next slide, please. In terms of cost containment, the applicant states that the proposed project is not anticipated to have an adverse impact on competition in the Massachusetts healthcare market based on price, total medical expense, provider costs, or other recognized measures of healthcare spending. The applicant aims to harness operational efficiencies that are created through the hospital's shared campus with the Meadows. Such efficiencies may include bulk purchasing, shared contracted services, and sharing of certain back office services such as housekeeping and dining. The applicant anticipates this will result in cost savings to the hospital. Though the applicant does not plan to make significant changes to the hospital's clinical operations, it will no longer use Vibra Hospital LLC or Vibra Healthcare 2 LLC corporate or administrative functions, which the applicant expects will significantly reduce the corporate overhead expenses. The applicant also plans to discontinue the use of the Vibra Travels program, which is the hospital's travel staffing agency. The applicant anticipates that this will significantly lower the fees associated with staffing. In support of this effort, the applicant anticipates offering a competitive compensation and benefits package. Next slide, please. In terms of improved health outcomes, the applicant plans to analyze the hospital's quality assurance data and target areas of focus. The applicant is planning to concentrate on the hospital's rehabilitation, dialysis, and telemetry services to provide comprehensive care and optimize its resources. The applicant also stated its goal to increase clinical acuity in the hospital and to ensure the facility has the resources and personnel to accept higher acuity patients. Better access to long-term care has the potential to improve outcomes for patients as well as improve throughput for acute care hospitals. Next slide, please. In terms of delivery system transformation, the hospital will consider the needs and challenges of each patient, along with the patient's care continuum, and work to begin identifying post-discharge concerns upon patient admission. For example, as discussed in Factor 1C, the hospital holds regular interdisciplinary team meetings to discuss patient discharge needs, which enables case managers to coordinate with providers that will be involved with the patient's post-discharge care. The applicant recognizes that post-discharge care requires a variety of resources and works with home care agencies and non-providers as appropriate to address clients' other supportive needs. For example, working with home improvement retailers to install in-home grab bars and other modifiers and provider special equipment. In addition to processes that are already in place to address patients' social determinants of health, the applicant stated its plan to explore additional opportunities to expand its contributions in the local community upon approval of the proposed project. Although it serves a patient panel from a broad geographic area, the hospital is in a rural area with limited public transportation. As a result, the applicant plans to implement transportation services programs for eligible patients and their families with local access challenges. This includes connecting with local hotels to develop potential discounts so that families and friends can be local while their loved ones are in the hospital. Next slide, please. Factor 3 covers compliance, and an analysis of this factor resulted in the following. The Determination of Need program staff has determined that the applicant has provided evidence of compliance and good standing with federal, state, and local laws and regulations. Next slide, please. Factor 4 assesses the financial feasibility and reasonableness of project expenditures and costs. To analyze compliance with this factor, the applicant must provide evidence that it has sufficient funds available for capital and ongoing operating costs necessary to support the proposed project without negative impacts or consequences to the applicant's existing patient panel. The report is certified by an independent CPA. Next slide, please. As a result of an analysis of Factor 4, the CPA concluded the following. Based on the applicant's financial resources, as well as existing relationship with lending institutions, this process is expected to be completed pursuant to the terms of the asset purchase agreements. We have no reason to believe that the applicant will not be able to obtain financing. Based on the projected financial information prepared by the applicant, the proposed project is financially feasible. Next slide, please. Transfers of ownership are exempt from Factor 5, relative merit, and Factor 6, community health initiatives. Next slide, please. The holder will report on the following outcome measures for a period of 5 years post-DON approval. 1. In terms of increased capacity, and the applicant improving staffing levels, the holder will report on the following. Measure A, the applicant will report annually on the facility's capacity using the current 50% capacity as a baseline. Measure B, the applicant will report annually on the direct care staffing levels in FTEs, providing the current FY 2025 staffing levels as a baseline. In terms of monitoring as it relates to this measure, the holder will provide an analysis for any reduction in capacity and/or staffing levels, including a plan to address these losses. Next slide, please. The holder will also report on 2, patient satisfaction scores, 3, clinical quality, vent-wean rates, and 4, clinical quality, new or worsened hospital-acquired pressure ulcers. In summary, based on the review of the materials submitted, the DON program finds that the applicant has met each DON factor for the proposed project and recommends approval of this application.
Thanks, Dennis. We're going to open it up now for questions from council members to the program staff and to the applicant. As a reminder, representatives of the application should introduce themselves prior to speaking for the record. And as usual, we'll go to Mary first.
Thank you, Commissioner. And I want to thank the applicant for their interest in operating a healthcare facility in Massachusetts and addressing the multi-year problem that we have had with throughput through the continuum of the healthcare. At the same time, however, I do want to share with the applicant, I do have concerns about a new private entity that was developed within the past year of 3 owners beginning to operate a hospital, a long-term acute care hospital in Massachusetts. And I'm hoping through my questions, some of those concerns can be answered, Commissioner. So I'd like to just begin with talking a little bit about the process. Vibra has owned and operated the LTAC that was in Springfield that closed. The satellite, if I understand correct, at Leicester stayed open as the main hospital of 46 or 47 beds that's been running at 50% capacity. On that campus, which is a lovely campus, is the Meadows Nursing Home. And just as a note, that nursing home, I believe, according to the CMS website, is now a 1-star nursing home, which is the lowest level of rating of a nursing home. I believe there's been continuous monetary penalties of the nursing home. That's an issue of itself. What I understand by reading this application is that the new owner, Everest, will purchase the hospital, the nursing home, and from the REIT, which I believe is Medical Properties Trust, will also purchase the property and the equipment. That's a question. Does the property and the equipment come? And that the real estate and the equipment and the debt service will be owned and operated by a separate entity, which I believe is also owned by the 3 operators. So I think what I'm really trying to say here is that we've had private owners come into hospitals in Massachusetts over the past many years. We want to be really clear on who the owners are, who owns the real estate in the capital, who's responsible for the operations. And as well, I would ask the owners, the 3 owners, to share their background. I myself have been involved in long-term acute care hospitals, skilled nursing facilities, rehab hospitals, the post-acute network in Massachusetts for decades. And operating a long-term acute care hospital requires an expertise that is very different from nursing home, from rehab hospitals, from home care, from other post-acute levels of care. And as reading the background of the 3 owners, I do not believe that any of you have operated or been involved in the operations of a hospital in the past. That's very important to the Commonwealth and to the citizens and the patients and the staff who will be working in these hospitals. Those are some of my initial questions, Commissioner, to the owners, if we could start there.
Yes. I'll pass it to the applicant.
Hi, thank you very much for your question. My name is Edith Danziger. I'm the Executive Director of Operations for Everest Hospital. So I appreciate your question, and it's true, our background is in other areas of the healthcare continuum, not necessarily in LTACs. For that reason, we're leaning into Whittier Health Group, and we're leaning into their expertise. We have a relationship with them where they're going to help us with the nuances of the LTAC space.
So will you be having a formal I was reading a CPA from HMM, and in there it's suggested or noted that you will have a management agreement or a consulting agreement with a provider, an LTAC provider of 20 years experience. Will it be a formal arrangement, and how long will that arrangement be for?
So yeah, it is a formal arrangement. I believe it is a 3-year arrangement to start, and then it'll continue from there, as needed.
Okay, so there will be an arrangement. And the actual real estate and the capital equipment, is that owned and operated also by Everest or by the real estate REIT that you'll be developing?
So it shares the exact same ownership. It is a separate company, just for legal reasons we separated it, but it shares the exact same ownership of the actual operations.
A couple other areas of question with that. So the operators of the hospital license will be the same operators of the real estate trust. Okay.
Sure.
So the staffing issue right now with Vibra travel service coming in for the census of 24, you stated in the application that you would no longer be using that. How do you plan to backfill over 50% of the staff and maintain a 24-bed census and in 18 months go to a 90% occupancy?
So we intend to work on staffing using some of so first of all, I'm going to be intimately involved in the staffing, and I'll monitor it. I do have extensive experience in staffing of healthcare facilities, and we intend to have referral bonuses. We intend to have a new hire bonuses. We intend to work with schools to try to get young applicants, new applicants that are just entering the space, to have them potentially come do their rounds within the facility, and then give them an extensive training and have them start their career within the facility. We intend I have a software that I've used for many years. I found very successful in the hiring process. It uses technology to help manage the workflow better, and I find it very successful in recruiting applicants. I guess, and we also intend to work on retention. We intend to make sure that it's a place that the people that are currently there want to stay. We find that when we first bring in applicants, the first 30, 60, 90 days, you tend to lose the most people. So we intend to work with the new hires closely to make sure that they are satisfied, and they'll stay. We're going to do exit surveys of those if people do choose to move on, to try to better understand why they choose to go elsewhere. I guess amongst other things, those processes.
The other area that I did want to bring up to you is this. Again, I'm looking at the HMM CPA report, which is based on 1 year of Vibra's losses this past year going forward, demonstrating your first year of losses, you expect a second year gain, and that is your EBITDA and your EBITDAM. I mean, I think it's concerning that after rent and depreciation and debt service, that there will be enough left over for the staff and the capital needs of this type of facility. So I do think it's an aggressive financial review of expecting year 2 and 3 of an LTAC that's currently operating at a loss, operating at 50% census, and taking on a new owner in the market, and the capital needs that will be needed for the property, both updating the property and the ventilator equipment, the supply chain equipment, much that will be needed. It does seem like an aggressive financial review by the CPA, which you provided the information to. So I do have concerns about the financial projections as well in this level of care in a more rural community. As well, the current volume of patients that are there from out of state. There are quite a few patients from out of state currently, and the idea here was to be able to address the throughput of the Massachusetts community, specifically assume UMass and some of the UMass environment. So I did wonder if you could respond to that.
Yeah, so I mean, I believe that one of the census is obviously the biggest factor of the lower revenue. Running at 50% capacity, if we could only increase, we don't need that many more. It's not that hard. I mean, I shouldn't say it's not hard, but if we get a reasonable amount of more staff, 20, 30 individuals or even less, that would enable us to be able to increase our census dramatically. That would have, that would, first of all, it would help through the throughput of Massachusetts, of the surrounding area within Massachusetts, and we believe that if we were successful in that, and we believe we will be successful in that, it would have very dramatic results in the financial, and it would bring the facility profitable pretty quickly. So in 2 years to be able to get 20 staff members and by that way increasing the census, we feel is reasonable.
Oh, okay. I appreciate your energy around that and desire to grow that service there. It is it's a very tough market for staff, especially these patients are coming from possibly an ICU or the highest level of acute care to a hospital transfer. I did see the transfer rate was under 20%, which is a good number. I did look on LTAC Compare on the CMS website to see how the current operation is working. This is just a very high level of care. It is not comparable to long-term care, which is a home for seniors as their last stage in life. And this is and the need for the best equipment, contract providers, supply chain, is really the level of an ICU or hospital level of care. And for owners coming in who do not have that experience and will be a private organization taking management fees, paying rent, have debt service, I continue to be concerned about this without other parameters, which would be that management agreement with a very seasoned LTAC provider, with a concern about deferring any management fees for a year or two until there's a successful bottom net operating income return, so that the staff are paid appropriately and there is equipment and there is an opportunity to make this a very high quality hospital as well. So I will, Commissioner, probably make some recommendations regarding going forward with this ownership change. Vibra's been in this business for quite a long time, and they've been in Massachusetts for quite a long time. And for 3 years, have been wanting to move out of Massachusetts. So I just want to be sure that this transition would be positive for the Commonwealth. Thank you.
We'll move on to Dr. Subbaraman.
So first of all, I just want to say I second, I think, a lot of Mary Moscato's concerns, and they were very nicely articulated. What was concerning to me is, I mean, looking at table 4 of the DON application, it's quite evident, and this squares with what we know about LTACs, that there's a huge need for LTACs. There are a lot of referrals to the facility under Vibra as it currently stands. But then when we look at table 1 of the DON application, the issue is clearly that not the number of beds that may be available, but really staffing. And what didn't really, feel sufficient to me in this application was, if the issue around financial viability and quality of care for patients is around staffing, and as Mary Moscato clearly sort of articulated, these are very high levels of care. You need advanced care providers, respiratory therapists, people who are very well trained. If the issue is around having enough staff to actually have those beds open, because the issue isn't referrals in terms of financial viability or the need for LTACs, and there is a need. The sort of response on the part of the applicant, if I may say, seemed to be that the traveling staff would somehow be converted into permanent staff. And that, to me, it doesn't seem to make a lot of sense. I mean, my understanding of traveling nurses or locum tenens physicians or whatever, staff are oftentimes more mobile, is that they're often doing this for sort of higher compensation. They may not be located in Massachusetts. So I'm sort of very worried about, Vibra right now is not able to sort of maintain this facility. How would these, the applicants then be able to staff more beds very rapidly in a market where we don't have enough providers without a very, very clear and much better articulated plan to do so. And then that leads to concerns about patient safety and quality of care, especially in an LTAC. So those are my questions, just to put them out there.
If I may take an opportunity, my name is Rebecca Roman. I'm a consultant working along with Everest and with Mr. Danziger in this project. And I bring to the table over 20 years of experience in the LTAC industry. I've been working with Whittier Rehab Hospital and will be the consulting partner. Certainly not running the operations, but consulting. And the points brought up are certainly very appropriate. And in regards to operations, our seasoned experience in the industry is something that we're going to be sharing with the Everest individuals and with Mr. Danziger to be able to make sure that the operations are being run in a safe manner. We're very familiar with the patient population. We're very familiar with the services that are required to manage the patient safely, to have positive outcomes. And so we'll be making sure that that's something that is implemented throughout the course of our agreement. In regards to the staffing, Mr. Danziger did highlight the fact that working on converting the travelers is going to be a goal. That's something that we've been successful in doing at one of our other locations based upon the COVID staffing crisis. And when individuals are comfortable in an environment, they quite often want to remain in that environment. And there are other ways to compensate them from a benefit standpoint to encourage them to stay. It's not always going to be the higher rate. At one point in the pandemic, everyone was fishing from the same pond for staff. It became very competitive amongst all of the settings, regardless of your level of care. And it seems to be improving in terms of candidates out there in this day and age for staffing. So I do think, as Mr. Danziger highlighted, that if we focus on them being competitive, having appropriate benefits, looking at opportunities to provide loan forgiveness, education, things like that can be beneficial in terms of recruitment strategies without necessarily taking away from another environment. Partnering with the schools is going to be important, but also making sure that you have staff who are capable to provide the training. And that's an ongoing goal that they've discussed.
Thank you, Rebecca. Kathleen?
Yes, I just like to point out you have many articulated just now, Mr. Danziger, and in the report, ideas of how you're going to go out and recruit staff. But just want to point out that this is not going to solve a workforce shortage underlying problem that we have in the Commonwealth, and that there are going to be providers all over the Commonwealth competing for those same staff at the same time, who are existing, who have been operating here, and who are familiar with the Massachusetts territory. So that is just wanted to kind of underscore that point. I also had some questions. Ram Subbaraman had some questions about Table 1. I did too, which I think is an important table in establishing demand. That I saw some inconsistencies. The issue for the declining capacity, which was dramatic in a number of unique patients between 2020 and 2023, I think it was something like a 29% demand fall in unique patients. But the workforce, the staff beds only went from 28 to 27. So they were not moving in parallel. So I didn't understand how the workforce shortage was the main issue. There seemed to be something else going on here. And then the other question I had was around dialysis. Some of the concern was that dialysis service was removed, and that now that is going to be restored, and that's going to make a difference. When I think of a patient needing dialysis, most patients are not residents in long-term care when they need dialysis. So I didn't understand how that was going to play an important role, and what are the factors that are going to bring that capacity back up. Some of these numbers didn't really compute for me. So I'm hoping that you can clarify some of those concerns that I had.
Thank you very much for your question. So That is our understanding from Vibra, that their largest challenge is in terms of staffing. We are also simultaneously going to work on increasing census. You can also see within that table there was a drop of referrals that were received from last year, from 2 years ago to last year. So we intend to work on that as well. I think that can potentially be a contributing factor, although per Vibra, staffing is their largest challenge. Regarding dialysis, you questioned. I'm not sure I fully understand the question. I'm not sure if I'm properly answering it, but if I understand correctly, you wanted to know. Better yet, would you be able to explain your dialysis question one more time?
Well, dialysis is a service. It's a procedure. It's not like a hospital or a provider. I didn't understand how the removal of the dialysis service and the return of dialysis service is going to make a very big difference in the number of patients filling the beds.
Understand.
Because renal failure was way down the list on the table of the common DRGs that you cited.
So like you said, it is lower on the DRGs, but I believe that if someone does have renal failure along with other comorbidities, it may not get that DRG, but they may also have renal failure. A lot of times, people would have multiple comorbidities at the same time, so it does limit some of the ability to take patients that also have renal issues due to the fact that they didn't have in-house dialysis. That service is it should be up and running in the next week if it's not already up and running. But Vibra has worked to reinstate that service, so that will open them up to both people with renal DRGs and people with other DRGs that also have renal issues.
Okay.
Mary?
I'm sorry, Commissioner, I had a few more questions, and they were metrics related to LTAC. I do see that the current operation of the campus, the LTAC would be responsible for about 36% of the cost because you're sharing the cost with the nursing home. And the nursing home being under concern and operations right now, this is hypothetical, but if the nursing home was to close, then the LTAC would be responsible for all of that cost, which would change your pro forma here in the HMM CPA report. Is there any concern that would happen?
So thank you for your question. Absolutely not. I'm extremely comfortable in nursing homes. I've seen what's going on in the nursing home. Vibra, although they do have extensive knowledge in LTACs, I believe this is the only nursing home they've ever operated, and we've seen a tremendous amount of opportunity that is not being addressed. One, you mentioned the continued civil monitor penalties. That was a very simple penalty related to non-reporting. That there's no way something like that can happen if with familiarity in the system. So the opportunity in the nursing home is tremendous, and we're very confident that it would maintain sustainable and profitable. I think the Vibra very much relied on the hospital to sustain the nursing home. That could have been part of their challenge. We believe very strongly the nursing home will be independently strong, and therefore would not be a burden on the hospital whatsoever. On the contrary, would benefit the hospital.
Thank you for that commitment. That would be important to all of us and to that community. The other point is you're currently running at a 35-day average length of stay versus, you're close to the 25, which is the LTAC metric. So couple that 35-day length of stay with the staffing needs kind of getting hit on both ends here. So again, I look at this pro forma of year 1, 2, and 3 and the CPA report. Again, this is another reason I feel this is very aggressive. You have over $350,000 in your rent in your debt service, and for one organization, how that impacts another is what we're seeing with private companies, and we are overall concerned that would work for this campus. The other question I have, I just had a couple more here. Sorry, Commissioner. We did talk about the quality. Thank you on that. And if I'm correct, the Medical Properties Trust would no longer be part of this campus?
Correct.
Yeah, correct. Okay. And we did talk about workforce, but in looking at some of the metrics for the current operation of LTAC, by a national provider of Vibra, you would need to be able to improve on those in less than 18 months in order to make your CPA report work. And I just want to highlight, I think that's very progressive. Even if Whittier is helping you and you have experienced people, to hire staff and train them takes months. And, I think this is something really overstated. But after operating the LTACs myself for over 30 years in the Massachusetts environment and being very involved both at the American Hospital Association on the long-term chronic hospital section of the Massachusetts Hospital Association as the non-acute hospital representative. This is to operate an LTAC at this level quickly of 18 to 24 to 36 months. It will be a challenge. Thank you, Commissioner.
Thank you, Mary. Robert?
Hi, first a comment for DPH and just wanting to raise a little bit of my concern and frustration that when asked earlier in review of the application for suitability related considerations related to the sale of the nursing home, it was reinforced that there aren't those types of considerations. So I would ask in your review of the CMR for nursing homes and the sale of nursing homes that we evaluate suitability associated with the sale. Because I understand that Dennis and his team can't review against regulations that don't exist, but it's just pointing out an omission in our regulatory structure for sale associated with.
Robert, I'm sorry, can I interrupt you there? We do have suitability review for long-term care facilities. It's just not part of the DON program.
Okay.
It's part of the licensure and facilities. So there are certainly robust regulations for the suitability review for long-term care transfers.
I thought so. So I was concerned then when we're talking about a sale, we're not including a review of the suitability associated with the long-term care portion of the sale. So it just seems like a glitch in the process, and I'd like to understand how to close that gap because it doesn't seem that we're answering that.
Processes, Robert, that work in parallel. One is the determination of need program, which is for acute care hospital transfer of ownership. One is the licensure process where suitability of the owner is evaluated. They happen in tandem, but this particular portion of determination of need does not bring in the suitability pieces that is evaluated separately by the department staff.
Okay, so then the suitability of this new licensee would be reviewed, and that would be done after a decision about the approval of the sale.
Yes, the determination of need portion of it, yes.
Okay, so then there could be a situation where they may not be determined suitable to operate after the sale has gone through.
Correct.
Okay, is there any way that there can be a link of the approval, the ultimate approval of the sale of the DON on the approval of the license? Because it does, they're separate, I understand, but it doesn't seem as if they're linked.
I think that's something we can take back, Robert. I'm a little bit worried that we are bound by statute and the way that the statute is written. Determination of need is not by statute allowed to evaluate the suitability. Licensure by statute is required to look at suitability. And so we have to fit within the law in these two processes. But we can take that back and figure out timeline. I think you should be reassured, though, that no transfer of ownership would result in licensure and operation absent an evaluation of suitability of the management.
Okay, thank you. And I think you're hearing my concern to make sure that one informs the other. I think that's be very important. Okay, thank you. In terms of the presentation by Mr. Denziger, I heard that staffing levels was limiting census and that the aggressive work on increasing census would improving staffing would increase census. In the table that's been referred to, it looked like staff beds went down 20%, but census went down 30%. So as Mary pointed out, it's not quite in step. And I note that UMass, Bay State, and Mercy are your primary referral sources. I was wondering what those referral relationships are like, if you've explored and talked with those three referral sources, related to the pending transfer and how they may be sustained going forward to ensure your referral base.
So thank you for your question. I have personally not spoken to those referral sources yet, but we do understand that there's a lot we can do on the actual referral side of it. Currently the liaisons that are working for the hospital in question are also simultaneously working on Vibra's other facilities. So there is somewhat of a dual mandate that they have, and I believe the staffing, the census is doing much better in their primary location. So we do believe that by the virtue of having it separate, and therefore the liaisons will be independent. They'd be more focused on just staffing those facilities, this facility itself, and then you don't have that conflict where you have one resident, where they're pulling the residents towards their main campus. Also, they're all working out of the main campus. There is no marketing liaisons or admissions process in that facility. It's all running either out of the main campus or out of homes, out of their individual homes. So we do feel like that is a big impediment to being successful. So I mean, that amongst other, we're looking to, we're going to have to work on building up the marketing liaisons and the admission process with a number of tactics in order to be able to build that up.
Okay, thank you.
Seen any other hands? And I'm wondering, Mary, if I might call on you. You had referenced an amendment to the conditions of the determination of need, and I wonder if you have thought those through.
So I have some thoughts on that, Commissioner, and I look for other council members to participate and enhance some thinking with this. But at this time, Commissioner, my motion would be to defer approval of this DON application until we receive some additional information. And that would be, or I could do this through, as you just mentioned, some conditions. So I would ask for council members to help me with this. One is a agreed upon management agreement, a formal management agreement that has been signed to operate the day-to-day operations of the new Everest Hospital. And that would be by a experienced LTAC provider. Second would be to be able to have more information related to the staffing. Specifically, if Vibra takes their travel out, what's left for the staff. 3, physician staffing, as the doctor noted, is very critical for an LTAC, 24-hour coverage. And we didn't speak about the physician coverage and how the quality of care would be managed. The quality program would be managed by the physicians and their background. So that was another area of concern. And as well, this volume development. What we do know is that the CMS just promulgated their LTAC regulations for October 1. The increase is 2.4. The CPA report identifies 3%. So we're already behind on the projected revenue. So I do believe that the revenue projections should be reevaluated as well. I'm not sure, Commissioner, I could list a few more, how you would like me to take my motion.
Well, I want to see if others on the council have thoughts. I will say, Mary, I think that those are substantial asks that are probably not conducive to just a simple amendment to conditions, and potentially something that we should take back, work with the applicant on identifying the right information, and then getting it back to the council.
My
Dr.
reason,
Superam.
yeah, my reason for deferment.
I just wanted to fully support, Mary's suggestion for deferral and, maybe a return of the application, if that's the primary suggestion, if I've heard that correctly. For me, the big concern is, as articulated as Mary sort of lists as one of the many things that she identified, was really having a plan, a really robust plan for adequate staffing, which I didn't find sufficient, and it didn't seem to square with what was being articulated in terms of the fact that there were a lot of referrals, yet at the same time, they didn't have enough staff to actually take those referrals. And there was actually somehow still a decline in the number of patients who were sort of accepted and being cared for in the LTAC. And so that all speaks to some really major challenges with staffing. And I just don't see how it would feel good to sort of move forward without a more robust plan on that front, along with other points that were very nicely articulated by Mary.
Are there comments or questions from the council?
Yes, Commissioner. I just wanted to say, I'm not sure if Mary's initial comment about getting more on the background of the three partners was ever responded to.
I don't think it was in the discussion, although it seems as if we're moving in the direction of asking for more information, and we could ask for that information as well to be provided to the council.
I have a question, Commissioner. So I too stand in support of potentially delaying and figuring out a pathway of getting additional information. Also in agreement, would love to see more on the background of the owners, as well as more information regarding, I know it was mentioned that there would be training of the new staff as they try to get, I think I heard 90% staffed. I'd love to hear more of a laid out plan on what that would look like to ensure quality to the patients that will be residing at the facility. And my question to you is, if this is more than a deferral and we go back and ask for more information, what would this look like for the council to be engaged in this process?
So the department staff, and Dennis, keep me honest here, department staff would go back to the applicant and ask a series of questions, obtain that information, and amend the staff report with the updates of that information. They'd be able to then share that back with the council prior to our next meeting. I imagine we'd be able to do this in the next month and be able to reconvene in September. And then at the September meeting, you'd be presented with the new information or summary of the new information, additional opportunity for questions and discussion, and then a potential motion at that meeting.
That is correct.
2.5 years, I figured it out.
Thank you, Commissioner.
Robert, you have your hand up. Oh, you're on mute, Rob.
Yeah, I would also ask, within the right and left azimuths that'll keep me honest from Jacqueline and others in terms of what we can and can't ask related to the long-term care component of the campus, if the applicant can address the comment that Mary made relative to their one-star status, and if there's the ability for us to ask how they're going to be responding to improving the quality of care within the long-term care environment. As that is part of the sale, I would like for it to be spoken to in terms of how that quality of care will be addressed.
I defer to Jacqueline. I imagine we can craft some questions and get some information. I'm aware of the fact that this is a determination of need ask on the transfer of ownership of the LTAC, not of the skilled nursing facility. And so any decision by the council needs to be based on the viability of the transfer of ownership of the LTAC itself.
Correct.
Dr. Simpson, you still have your hand up. Is that from before? No. Okay. So I think if we sort of captured the information that people have asked for, I will see, Mary, I'm going to try to use your words here. If there is a motion to defer action on this determination of need application until we receive some additional information from the applicant.
That would be terrific, Commissioner, and we would look forward to this additional application information.
Great. Is there a second to that motion?
I second.
Thank you, Dr. Subramanian. We will now do a roll call vote for that motion. Craig Andre.
Yes.
Dr. Archer.
Yes.
Lisette Blondette. Kathleen Carey.
Yes.
Emily Cooper. Robert Engel.
Yes.
Marcia Hams. Stuart Landers.
Yes.
Tom Mackey.
Yes.
Mary Moscato.
Yes.
Dr. Stinson.
Yes.
Dr. Subramanian.
Yes.
Dr. Boturo. and Aria Zayas.
Yes.
Thank you all. I'm going to vote yes as well. And with that, the motion is approved. So we will thank the team that has joined us from the applicants and welcome them back next month, we hope, with some additional information for this council.
Thank you for your time.
Thank you.
All right. We are now going to move on and begin the vaccine-specific portion of this meeting. And I'd first like to invite Dr. Catherine Filo, Director of the Office of Healthcare Strategy and Planning, Farisa Hassan, our epidemiologist, and Eileen McHale, Healthcare Associated Infection Coordinator, to give us an update on Massachusetts healthcare personnel COVID-19 and influenza vaccination in healthcare facilities and emergency medical services for the 2024-2025 season. As I mentioned earlier, joining us this morning are several experts, epidemiologists, infectious disease experts, pediatricians, and after this presentation, we're going to have a roundtable discussion focused on the current state of vaccination in our country and in Massachusetts. After the roundtable, we're going to open it up for a question and answer from council members. So I just ask that you bear in mind as we welcome our next presentation and potentially ask questions of our presenters to remember that there will be an opportunity to ask additional questions on this topic later. So with that, I'm going to pass it to Dr. Filo.
Thank you so much, Commissioner, and thank you to our Public Health Council members for this opportunity to share about the past season's flu and COVID vaccination efforts in our healthcare personnel and support our department's commitment to being transparent with our data. I think Commissioner Goldstein's opening remarks really set the stage well for sharing this update and the continued critical importance of supporting evidence-based vaccination. Next slide, please. Before jumping into the data, I first want to just provide everybody with some background about COVID and flu vaccination in our healthcare personnel and specifically about these reporting requirements. So I think as everybody is well aware, our healthcare personnel, whether that be our certified nursing aides in a long-term care facility or paramedics working on an ambulance, are at high risk for flu and COVID exposure and illness. But then they also can potentially be a source of transmission within healthcare settings, often unknowingly. And so annual immunization decreases the risk of flu and COVID. And, as we know, it's really the best method of preventing serious complications. And so this has long been a priority of the department that we take, whatever efforts possible to be able to prevent flu and COVID and certainly reduce the risk of transmission through vaccination. We also want it to be a commitment, not just here at the department, but at all of our healthcare facilities and our emergency medical services. Vaccination efforts, though, don't operate in a vacuum. We do also have a multi-pronged approach where vaccination is obviously the keystone, but we encourage other, core infectious prevention and control strategies. So implementation of respiratory hygiene and cough etiquette, particularly when there's higher rates of respiratory virus. So that would be, potentially universal masking within healthcare facilities when rates are high, particularly obviously during, patient or resident encounters. Making sure that, there's the administration of antiviral treatments like Tamiflu when appropriate. Also making sure, there's good signage and hand hygiene and masks available for visitors and patients, upon request, and encouraging and educating everybody about obviously the importance of putting these measures in place, as well as obviously making vaccination available. Next slide, please. So as a condition of licensure, and this includes, as a result of some efforts that we put in place a couple of years ago in our Department of Public Health Regulations, all healthcare facilities, so this is hospitals, ambulatory surgical centers, dialysis, clinics, nursing homes, rest homes, hospice programs, adult day health, and emergency medical service are required to ensure that all healthcare personnel are vaccinated annually with seasonal influenza and COVID vaccines, obviously, as recommended, unless the individual claims an exemption. The healthcare facilities and EMS are required to educate about the benefits and the risk of vaccination, and then either provide vaccination or support vaccination of personnel at no cost to the healthcare personnel. and then report that information to the department, as we direct in some of our sub-regulatory guidance. And you can see all the references here. Next slide. So then to frame, the implementation of these requirements, we have set goals here within the department. And so namely, we've set and implemented a goal of 90% or greater vaccination rate in healthcare personnel at all our licensed healthcare facility and emergency medical services. And this goal comes historically from some of our national partners in the National Healthy People. It was a 2010 and then a 2020 target. It's no longer part of the Healthy People goals, but it is a metric that every year we do have, a robust conversation about whether, we're continuing that goal or looking at other goals. It is one that we intentionally adopt and really push for all of our healthcare facilities and EMS to be able to meet. And then again, align certainly with CDC recommendations that, everybody get, including healthcare personnel receive an annual influenza vaccination. So with that in mind, we want to transition over to our, I want to ask Farisa Hassan to take the next piece and share the results of vaccination efforts in all of our different settings. Thanks.
Thank you, and good morning, everyone. So healthcare facilities and services licensed by DPH are required to report healthcare personnel flu and COVID vaccination data through one of three mechanisms. For acute and non-acute care hospitals, ambulatory surgical centers, dialysis centers, and nursing homes, the state has aligned with federal reporting requirements and accepts data through the National Healthcare Safety Network, also known as NHSN, which is managed by the CDC. The remaining provider types report directly to the state, where rest homes and adult day health programs report through the healthcare facility reporting system, and emergency medical services clinics and hospice programs report through an online survey programmed in REDCap. This was the second year that hospice and EMS were required to submit vaccination data to DPH. Next slide, please. So reporting deadlines and definitions were also aligned with federal requirements wherever possible. And in this past respiratory virus season, the season was defined as October 1st, 2024 to March 31st, 2025. Providers were required to report the total number of healthcare personnel who worked at least one day on site within the season, and among those, the total number of personnel who received an annual flu vaccine, the total that received an annual COVID vaccine, and the total that claimed an exemption for each vaccine type. Next slide, please. For each facility or service, we calculated vaccination rates by taking the total number of personnel who received each vaccine type and dividing that by the total number of personnel who worked on site at that facility or service. We then took all of those vaccination rates for the individual facilities and services and calculated a mean and a median by provider type. So we then compared the mean vaccination rates for each provider type with previous years of reporting. Next slide, please. Here we see the flu vaccination rates for hospitals. At the top of the slide, there's a table that shows the median flu vaccination rates for acute and non-acute hospitals for the most recent respiratory virus season, 2024 to 2025. While the bar graph below shows mean vaccination rates for the last 5 years. We generally see a downward trend in average flu vaccination rates among all hospitals, with acute care hospitals falling below the 90% vaccination goal when looking at the means. Unlike previous years, we did see in this past season, there were notable differences in the mean and median vaccination rates. For example, acute care hospitals had a mean of 83%, but a median of 95%. This difference suggests that while many individual facilities maintained high vaccination rates, there are few facilities with significantly lower vaccination rates, either due to many personnel claiming exemptions or being reported as having unknown status. While the state does not allow for facilities to report personnel as having unknown status, the federal reporting system does allow this as an option. Next slide, please. Similar downward trends in flu vaccination rates were seen for ambulatory surgical centers and clinics, while dialysis centers on average reported higher rates of flu vaccination in the 2024-25 season compared to previous years. Average flu vaccination rates among dialysis and clinics were around 60% this year, and among ambulatory surgical centers around 75%. Next slide, please. Again, there have been downward trends in flu vaccination rates among nursing homes, rest homes, and adult day health over the last 5 years. In season 2024-25, nursing homes and adult day health had an average of about 50% vaccination rates, while rest homes were higher at almost 70%. Next slide, please. So again, emergency medical services and hospice programs began annual vaccination rate reporting in 2023. And so they only have 2 seasons of data available. Average rates for flu vaccination in the last season were similar to the prior year, with EMS reporting the lowest average vaccination rates with a mean of 21%. Next slide, please. Here we've presented the mean flu vaccination rates for all provider types for the last respiratory season side by side. You can see that acute care hospitals had the highest average vaccination rates, while EMS had the lowest. Next slide, please. The current state annual COVID vaccinations reporting requirement has only been in place since 2023. So again, there are 2 seasons of data available. When looking at the last 2 seasons of COVID vaccination data, average vaccination rates have remained pretty low across all provider types. Similar to the flu reporting, there are notable differences in means and medians, suggesting a wide range in vaccination rates among individual facilities and services. When looking at hospitals and dialysis centers, their average COVID vaccination rates were very similar to those reported in the previous year, while among ambulatory surgical centers and clinics, average COVID vaccination rates declined. Dialysis had the lowest mean COVID vaccination rate among all provider types at about 5%. But it's important to note that with dialysis centers, they had the highest rate of reporting their personnel as having unknown vaccination status, meaning that the true vaccination rate is likely underestimated. Next slide, please. When looking at nursing homes, rest homes, adult day health, emergency medical center, emergency medical services, and hospice programs, all average COVID vaccination rates declined from the previous year. Rest homes had the highest mean vaccination rates among all provider types at almost 50%. Next slide, please. Overall, there has been a decrease in flu and COVID vaccination uptake among healthcare providers in Massachusetts, which is similar to the trends that are reported nationally. No provider type has reached the average 90% vaccination goal for either flu or COVID. When looking at the means, though acute care hospitals did reach this goal for flu only when considering the median. Among facilities, some facilities are reporting the personnel as having unknown vaccination status, which underrepresents the true vaccination rate. This is most prominent among dialysis centers. And with that, I will pass it off to my colleague, Eileen McHale. Thank you, everyone.
Next slide, please. Thank you. Thank you very much. So public health next steps for the upcoming season. So I think first and foremost, as has previously been stated, the importance of vaccinations is very strong from DPH, and we strongly recommend that all healthcare personnel are vaccinated against flu beginning in September 2025 when vaccine becomes available. DPH is also planning educational webinars, the first one for September 2025, and those will cover topics such as updated flu and COVID information. We'll talk about the activity both in Massachusetts and nationally, best practices to promote healthcare personnel vaccination, and highlight strategies that have been used effectively to improve data. Additionally, we're also planning a quality improvement collaborative to increase healthcare personnel immunization rates. The program components will work with facilities to help them identify the staff to work on this program throughout the season, help them develop and implement plans, and also to develop a standard way to monitor progress throughout the season. We hope that the lessons learned from this collaborative learning will be shared with other healthcare facilities. This update, as well as facility-specific results, will be available on the DPH website.
Thank you. We'll turn back over to you, Commissioner.
Thanks, Kate and Teresa and Eileen. And we can take down the slides for a second and we'll see if there are any questions from the council on these specific data, noting again that we have a roundtable coming up with further discussion around vaccination. Robert.
Yeah, sort of a corollary to this, I was wondering about outbreak metrics that we have for each of those different provider types, as we're seeing. And again, it is so disheartening to see the decline in the number of individuals who are receiving their flu and COVID vaccines. But I was wondering if we see, in a sense, the outcome of that decline, either in terms of outbreak in staff or outbreak in residents of those different facility types, and if there's been a level of correlation. Thank you.
Sure. So I think there's a couple of different points maybe to be able to respond to your question. I think first we do receive, like as an example, our Bureau of Infectious Disease and Laboratory Science cluster information. So when we do have 2 or more resident cases in a nursing home, that is reportable. So we do track the number of clusters. I think as many are aware, this past influenza season has been one of our worst in quite some time. And so certainly we did have, increased hospitalizations and increased deaths. And so I think while we wouldn't necessarily jump to, causal there, certainly, as we've stated time and again, vaccination is one of our best ways to mitigate, severe disease. And so certainly critical. We do also, meet with our hospitals, particularly during the respiratory season, on a very regular basis, often, at least weekly. And so we do get updates about the burden of staff illness, and we do track on a daily basis the number of staffed beds that are available in our acute care hospitals. And so we do see fluctuations during the particularly during the respiratory virus season, when sometimes beds need to be closed due to staff illness. Thanks.
I might add, Kate, to that. Robert, I think confounding this is the challenge to understand how facilities are using masking as a mitigation strategy during the respiratory virus season. While we have regulations that require a mitigation plan that may include masking, it's variable across the state who uses masks, when they use masks, and if that's only in response to an outbreak or if it is a universal masking recommendation.
Thank you.
Craig?
Thank you, Commissioner. My only question is I know there had been some bills to adapt or change the ability to get exemptions, whether religious or otherwise, around vaccinations, and I don't know what the status is of that. Can you update us on that?
Yeah, so those specifically reference requirements for school entry at kindergarten, grade 5, post-secondary education. And those bills had a hearing. I cannot tell you the exact date, but I believe it was 2 months ago in front of the Public Health Committee. There was a robust conversation during that briefing, during that hearing. And I would anticipate action in the legislature, but they are making their way through. There are various iterations of the bills that are slightly different based on the chamber from which they came, but they are. I would expect that we would see some action out of the legislature on that. Not seeing any other questions. And so if not, I will thank Kate, Farisa, and Eileen for the presentation and for sharing the data with us as we prepare for the next step of this, which is our roundtable discussion on vaccination. So as we're bringing folks in, I'm going to say that I'm incredibly pleased and really honored to be joined by colleagues from across our healthcare and public health system. We are going to spend the next 20 minutes or so hearing from these panel members, and then we're going to open it up to some questions from the Public Health Council. And so I will say who we have here as they're all coming on and getting the spotlight on them. We are joined by Dr. Michael Osterholm, Dr. Vincent Chang, Dr. Elizabeth Barrett, and Dr. Camille Cotton. And rather than butcher your introductions, I'm going to let you do it. So we'll start with you, Dr. Osterholm.
Thank you very much. I'm Mike Osterholm. I direct the Center for Infectious Disease Research and Policy at the University of Minnesota. I'm in my 50th year at the university. 25 of those years, I also simultaneously at the Minnesota Department of Health have a long and very dear track record in the public health arena. I'm very pleased to be here today, and I just want to say as an opening comment, for all those from Massachusetts, sometimes it's not always appreciated when you live with the expertise you have that's what it is, but much of the country looks to Massachusetts and the work that the Department of Health does there in terms of the efforts, and I think this is clearly one of those areas, so I look forward to speaking with you about that today.
Thank you very much. Dr. Chang.
Good morning, everyone. My name is Vinny Chang. I am a pediatrician, a pediatric emergency medicine physician, and a pediatric hospitalist. Those are my roles clinically. Currently, I serve as the interim president for Franciscan Children's Hospital and am an executive vice president at Boston Children's Hospital. My area of expertise with regards to this relates to my role as Chief Medical Officer at Boston Children's Hospital, and I helped lead our COVID response. I served on the state's COVID vaccine working group, participated in a number of panels with Bessie around COVID vaccination, and so really look at things from a system operations point of view with regards to vaccination and how we may improve uptake and the like.
Thank you. Dr. Cotton, we'll go to you.
Hi, I'm Camille Nelson Cotton. I am the clinical director of transplant and immunocompromised host infectious diseases at Massachusetts General Hospital. And on a vaccine front, I served on the Center for Disease Control Advisory Committee on Immunization Practice for 4 years. My term was over in June of 2024, so I was not one of the people who was briskly dismissed from the ACIP, but I continue to serve in the work groups. I was the chair of the shingles vaccine work group and the adult RSV vaccine work group. Work groups at the ACIP are hopefully temporarily on hiatus, but nonetheless, I remain involved, and my special interest is in the immunocompromised host and protecting them. Thank you.
Thank you. And Dr. Burnett.
Yes, good morning. I'm the Division Chief of Pediatric Infectious Diseases at Boston Medical Center, and my roles in vaccines and vaccine safety have included being a liaison to the ACIP from both the American Academy of Pediatrics and the International Society of Travel Medicine. And I'm also part of, or Boston University is part of the clinical immunization safety assessment project, which has experts from 8 national centers plus the CDC. And I'm also an associate editor of the AAP Red Book, which provides vaccine guidance as well. So thank you for inviting me.
Thank you for being here. As folks can see, we have some incredible experts joining us here for this Public Health Council meeting. I'm going to start just by setting the stage for folks. We have over 450 people who have joined us on this Public Health Council meeting. That might be a record for one of these. In the audience, we have state legislators, we have healthcare providers, professional organizations, there are advocates, there are partners from our other state agencies. We, I'm sure, have the media as well. And for them, I'm wondering, we have been using for the past 9 months the word unprecedented, probably too much, but it does feel as if we're living in unprecedented times. That suggests that there is a precedent of how vaccines are supposed to be approved and recommended in this country, a precedent of how the federal government is supposed to function in this space. And Dr. Cotton, I'm wondering if I can start with you as someone who served on ACIP. What is supposed to happen in that body and what is happening right now?
Sure. So ACIP is an independent group of people that make recommendations to the head of the CDC. It's important to realize that we actually work completely outside of the CDC. We work with the CDC, but we are completely independent. We are usually academics and other leaders in the vaccine field that have expertise on a whole variety of topics. Traditionally, it was a good number of pediatricians, and we've now expanded to include obstetricians and some geriatricians. And I believe that I was the first one to serve on ACIP that had significant immunocompromised host expertise. And so it's an independent body of people with a broad array of talents and experience. We have gone through extensive vetting so that we have no conflicts of interest, and that was done over many months. So we were very carefully reviewed and carefully picked. And unfortunately, many people don't actually make the cut due to often conflicts of interest or perceived conflicts of interest. There have been sort of a range from about a dozen to 15 of us. And we do go to the CDC for meetings 3 times a year. During the pandemic, we had, I think it was 36 or more emergency meetings on COVID-19 vaccines, which was literally, we're having a meeting tomorrow, clear your schedule. And those were all done virtually due to the nature of the pandemic. The way the system works is that the FDA reviews data, makes a decision on whether a vaccine is appropriate. So the the FDA approves vaccines, but does not necessarily determine how they should be implemented. So it's FDA approves, and then CDC makes a recommendation. And importantly, and perhaps this is one of the most important things, is that whatever ACIP states as a recommendation for vaccination, insurance is mandated to cover those vaccines. And that's whether it's a standard recommendation, everyone, over the age of 75 should get an RSV vaccine. Insurance has to cover all of that. Also, if it's shared clinical decision-making, insurance also needs to cover that. Insurance companies can take, my understanding under HHS policies, that they can take 1 year or longer to cover. So, for example, there was a recommendation made that people 50 and over with risk factors can get the RSV vaccine, and that was made at the end of June. And I'm cautioning clinicians that that may take a year or longer to actually have insurance coverage. Apparently, insurance can take 1 year plus the remainder of the policy period. So sometimes it's close to 2 years before patients can get vaccines covered. And then what's happened is that in this spring, all active members of ACIP, who I have to say were a tremendous group of very talented people from across the United States, very diverse experiences, really overall brilliant, really acknowledged as key leaders in their field, were all summarily fired, and a new body was appointed. It was stated that the people who'd been on ACIP had conflicts of interest, which again, we spent many months going over our conflicts. Some people resigned from things and whatnot. It seems that the current body of experts did not have that type of time span to be vetted, so I'm not sure how they were vetted. The current people on ACIP, I believe that there are approximately 8 of them. And I believe that there's only one person that has any familiarity with vaccine administration. And I don't believe that anyone else has actually been actively involved in administering vaccines, supplying vaccines, distribution, those type of things. And I'll leave it there, and I'm happy to have further questions that I am able to answer.
I think that's really helpful to ground us in what is supposed to be happening. And actually, what you kind of hinted at towards the end there is this broader infrastructure for vaccination in this country. You spoke about FDA's approval, CDC's recommendations, but those recommendations only matter if there's a system to distribute the vaccine and then administer the vaccine in a clinic and make sure the shot gets into an arm, or in the case of a very young child, maybe their buttocks. That infrastructure seems to be failing us today. It seems to be falling. We hear about these news reports of contracts being canceled by the federal government. We're seeing changes to the structure that Dr. Cotton just described. We're seeing the consequences of that, right, with the spread of vaccine preventable diseases in many parts of this country. I'm maybe going to turn it to you, Dr. Osterholm, and ask, what do we do when there is such a huge disruption in the federal system that has been bedrock to vaccine immunization infrastructure for so long? What do we do when that is disrupted? What's our plan from here?
Well, thank you very much. And Commissioner Goldstein, I'm sure all the work you've done here in Massachusetts can actually add to anything I say. But let me just summarize it quickly. On the night of the election, I stayed up most of the night and reread the 2025 document and fully anticipated after rereading that we were in for a very bumpy time in public health and specifically in vaccines. I even sent an email out to my staff the next day and said, I'm not going to be able to retire in the next 4 years. I published a piece in the New York Times in November saying that this is very likely going to be a major challenge with vaccines, particularly given the fact that Mr. Kennedy at that point had been named as who would likely be the new Secretary of Health and Human Services. The reason I just give you that framework, because at that time, a lot of us were all sitting there saying, can we do anything about this? What can we do? And nothing really dangerous or severe had happened yet. And so people thought maybe this was an overreaction. Well, I think right now it's very clear from a situational awareness standpoint that the worst has happened and it's going to get worse. And I think that's the issue. So the question is there anything we can do outside of what the federal government does? And let me be really clear, you cannot replace the ACIP. As Dr. Cotton has pointed out, it's a very, very critical organization that has legal standing that none of us outside of that have, both in terms of the issue of payers, the issue around what we know to be the case in terms of recommendations in general. And so what we looked at is said, well, what is the big gaps? And we actually were able to receive support from a philanthropic organization, the Lumbra Foundation, no conflicts of any kind with vaccines, and launched what we call the Vaccine Integrity Project at CIDRAP, the Center for Infectious Disease Research and Policy. And the first order of business was to do a focus group effort. 8 different focus groups from the entire vaccine enterprise were involved. We interviewed over 60 subject matter experts in this area and said, what are the gaps that are now occurring? And we came up with 8 of them, of which one primary gap was the fact that in order to make recommendations for the fall vaccine season, the viral pathogens of the fall vaccines, what were going to be the database you would use to judge how you ought to recommend these vaccines, given that that was a job that ACIP had always done. And they did it very well. And as Dr. Cotton even pointed out, the work groups were invaluable in helping to bring forward information that could be used. So at that point, we brought together our own, you might say, effort in this regard. 24 individuals from around the country, including several from Boston. And we put together basically a protocol to do a very similar kind of review that would be done by ACIP. In short order, in the last 8 weeks, it has been nothing short of a Manhattan Project in public health. We've identified and reviewed over 17,500 abstracts, double reviewed them. We have then reviewed all of those papers And we have worked closely with the medical societies to say we will provide you by late August a summary of all this information. We'll just turn it over to you. We're not here to make a recommendation ourselves. That's your purview. You've in the past based it largely on what has come out of the ACIP. You're not in the position to have that happen this time. And it's been a very remarkable relationship. In addition, we have, for example, we've done weekly updates on where we're at. We have one today in keeping with Commissioner Goldstein here. We've also kept the Association of State and Territorial Health Officials updated, the state and epidemiologists, et cetera. And we will this next week turn over a very large body of data in an event that will be held on Tuesday. And at that point, and we have also 4 individuals that we've identified who will actually spend time with our group in a formal review on a YouTube live event, including the editor of the New England Journal of Medicine, Dr. Rubens, one of the individuals, as well as Mark Siegel, the medical correspondent for Fox News, Oliver Brooks, who is a former member of the ACIP from Watts, and Caitlin Getolina, who is the founder of the local epidemiologist. And we will spend several hours basically going through all the data, asking the questions, what did you find, not find, et cetera. And so in short order, I think the message from us is you don't have to be paralyzed by what's happening right now. We can be creative. And I know that's what you've been doing in Massachusetts, and I'm sure hopefully we'll hear more about that later yet. But I think our goal right now is to continue to do these roadmaps of such for the vaccine so that, in fact, there will be a body of information out there that's comprehensive, current, and can be used in terms of making future recommendations.
Thank you. Thank you for all of that work. Thank you for summarizing it for us. And I think we're all, I will say, I am personally very excited to see the data and to see this be done in a very transparent way, a way that ACIP was committed to, and a way that I think we really deserve to make sure that we can analyze those data, we can make the right decisions with the communities that are most impacted. I want to sort of shift a little bit here. We're talking about process, we're talking about systems, we're talking about infrastructure, but underneath all of that is also the understanding that vaccines are good. Vaccines are a benefit. Vaccines are safe. I said it earlier in my remarks, with all due respect to the seatbelt, vaccines are the greatest public health intervention that we have ever had. And that fact is being challenged in this moment. And Dr. Barnett, I want to bring you in here and just maybe you can speak to us like a pediatrician, speak to us as you would speak to children and to families. How safe are these vaccines? And how do we know that these vaccines are safe?
Well, this is a question that is so important to get out to the public. And I think it's worth spending a few minutes just reviewing the process that vaccines go through before they reach the stage of the ACIP recommendations. And I think people aren't aware of the rigorous nature of clinical trials and how many studies are done before a vaccine is presented for licensure to the FDA. There are often discussions back and forth between the FDA and the manufacturers to address safety issues that are not completely presented when the FDA reviews the data. And so this process is really rigorous. And I think it got into a bit of difficulty during the COVID process with the use of terms like warp speed, and people took that to mean that possibly corners were being cut. So we had to explain to parents that no corners were cut. It's just that instead of working sort of a 9-to-5 workday, people were working 24 hours a day around the clock, 7 days a week to bring these vaccines to be available to the population. The second thing is that I know Dr. Cotton has already gone through the process of the ACIP. After the recommendations are made and vaccines are begun to be used in the population, there are many post-licensure safety systems that occur after that. This includes the Vaccine Adverse Events Reporting System, which is a passive surveillance system that receives reports from anyone. including patients, physicians, practitioners, manufacturers, about any adverse event that is then, these are reviewed. There is the Vaccine Safety Data Link, which is an organization which can do rapid studies of safety events that have occurred to determine whether there really is a signal and they're occurring more often with potentially a new vaccine or not. There's the organization project that I'm involved with, the Clinical Immunization Safety Assessment Project, which can look at specific adverse events in great detail, reviewing patient records, and then report about these events. And I think some of you may be aware of the V-Safe program, which was used with COVID vaccine, where we could report any events that occurred through our phones, and those data were used to report about safety events. So I think that the more we are aware of these processes, the more we can speak with parents and say, it's not only during the manufacturing process, the approval process, the recommendation process, but safety doesn't stop there. It's continually assessed as vaccines are used in the population.
Thank you for that. Another robust infrastructure, right? A very robust infrastructure. Yes. Dr. Chang, let's go to you. What's happening on the ground? What are you hearing from families and from children? What's the misinformation that's maybe coming into the exam room? And what are you saying in response to that?
Yeah, thanks. And just want to thank you, Commissioner, and the council members for having us all here today. I've had the privilege of practicing my entire career in the state of Massachusetts, and Dr. Osterholm talked about Massachusetts. Massachusetts has been a leader with regards to public health for this country for as long as I can remember, certainly as long as I've been practicing, by almost any measure. And one of the measures of that success is in our vaccination rates. For the longest time, Massachusetts had been leading the country with regards to the percentage of our children who have been vaccinated on the recommended vaccination schedule. And just as in the last presentation, we saw a slight dip in healthcare, we've seen a similar dip with regards to the vaccine uptake in the state as well. And I attribute that a lot to the phenomenon this vaccine hesitancy. And while the infrastructure and the safety mechanisms and all of that may be exceedingly robust, the decision to vaccinate a child still rests with the parent, generally speaking, with regards to childhood vaccinations. And so a lot of the work on the ground is just having conversations with families. One of the things I've learned, and I've had in tens of thousands of family encounters, beliefs and identity are inextricably tied. And if you challenge somebody's beliefs, you are challenging their identity. And so the trick is, how do we have conversation, not a debate, about the critical importance of vaccinating all of our, everyone, but in the pediatric population in general, without casting aspersions about one's ability to parent. I've yet to meet a parent who doesn't want to do best by their child from their point of view. And I think especially nowadays, where sources of information and ability are being called into question every day, it's up to having a trusted relationship. And I think that the pediatrician family patient relationship is still critical in terms of vaccinating our children. So we want to get at the heart of their beliefs, not in a challenging way, but in an inquisitive, concerned way. We want to ask why somebody feels the way they do. And sometimes the issue is not related to a fundamental, I disagree with vaccinations, but it may be an experience that they had or a family member had or something that we can address in a different way without challenging, again, their fundamental belief structure. I think these conversations are critically important. I think the only way that we are going to survive the 4 years that Dr. Osterholm's not retiring in is to continue to ensure that we use state and deliver vaccines to everybody who needs them, but I'm biased in particular to the pediatric population. And we do that by having good conversations, being good listeners, and sharing information that we believe, as Dr. Barnett talked about, are valid, are real, and demonstrate the safety and efficacy of the vaccines. I'm often asked as a pediatrician, would you do X for your child if this were your child? I try very hard not to answer that question, except when it comes to vaccines. I think it's critical for us as healthcare providers to be strong in our recommendations and to say, yes, this is critically important and we have to do this. It benefits not only your child, it benefits everyone in the state.
Thank you for that. I want to bring in Dr. Cotton here, and I want to first just sort of name my own conflict of interest here, which is that Dr. Cotton trained me as an infectious disease physician. I've been in the exam room with her. I know the importance of vaccines in her population. What are you hearing, and what are you saying to the immunocompromised population, a population that has tremendous risk for these diseases and a huge benefit from vaccination?
Yeah, so it is somewhat of a challenging time. I will say that, in general, I try, as Dr. Chang said, to really hear patients, hear what their thoughts are, hear where they come from, understand their perspective. And I think that is key always, always in anything we do in medical care. What are their goals? What are their philosophies? And I really try to hear them and then meet in the middle. And I actually spend a lot of time working on this. If the concerns are around safety, I try to share safety data. As was nicely mentioned by Dr. Burnett, the CDC has a wealth of safety data, and almost everything is available. Anything discussed at an ACIP meeting is available on the publicly facing slides, which I wasn't actually aware of until I served on ACIP, but all the meetings, all the slides are all available on websites. I do occasionally bring up some of that information to show safety. The amount of safety data we have for vaccines, especially COVID vaccines, is, I think, especially COVID vaccines, better than almost anything else we've ever done in modern medicine, which is, pretty astonishing. So just kind of running through what I know, what I can share with them, and then understanding the perspective of what happens when people aren't vaccinated and how I have taken care of many people who were under-vaccinated, some of whom have, unfortunately, many of whom have actually passed away, especially early in the pandemic. And for me, no one should ever succumb to a vaccine-preventable illness whenever possible. So I do spend a lot of time talking with people and trying to really encourage them. And we actually have a very robust program here across MGB where we strongly encourage all immunocompromised patients, which is about 7% of the US population, to be up to date on their vaccines. And it takes a little more time. I often find it to be a bonding experience and a learning experience for me as well.
Thank you for that. I definitely takes a little bit more time, having done many of those interactions in the exam room. I'm gonna ask one more question, and then I want to open it up to the council because I'm sure there are questions from them. I want to just ask everyone, maybe Dr. Osterholm, I'll go to you first with this question, but anyone should feel free to jump in. I think there are a lot of impacts of what's happening at the federal level, and as we're discussing the infrastructure falling, vaccine hesitancy increasing, misinformation, disinformation. I'm most concerned about the impacts on equity and the impacts on innovation, both of which have been really bedrock to Massachusetts for a long time. We are really laser focused on equity in our public health programming. And we are fortunate to have life sciences corporations in Massachusetts that have been on the leading edge of innovation. What do you anticipate? What do you think is going to happen in those spaces as we continue to see this shift at the federal level?
Well, I think, first of all, expect the unexpected and be prepared to respond to it, because I think we're going to see decisions made, actions taken that defy anything that we in the past would have thought possible. Just unilateral decisions on the availability of a vaccine made by a single person or very few people. I think those situations are very real. I think we also have to understand we are part of an international issue. We've been talking about the challenges with vaccination in children in this country and measles. And it surely has been a difficult year with almost 1,300 cases, the highest number reported since, we hit elimination status. But just think about this, we have 340 million people. Canada has 40 million people. They're almost over 4,000 cases of measles this year already. And if you look from an incidence standpoint, they are much, much higher in terms of incidence. Well, they are a lot like what we're seeing in the EU. This issue of vaccine hesitancy, vaccine reluctance, resistance is actually an international phenomenon. And I think that as much as we can focus on our own government and what they're doing, we have to realize if we didn't have this administration, but a very vaccine-friendly administration, we'd still be in a deep trouble. And I think that one of the things that we're learning is, first of all, there isn't such a thing as a vaccine hesitant or vaccine resistant person. It's basically a number of different reasons why. And if you go to and have an encounter with a certain individual, that encounter, even if it were successful with them, might not be successful with someone else who has very different reasons for why they have their vaccine hesitancy. So I think to get to your point, Commissioner, is that when we look at equity, when we look at the importance of that in vaccine, it's much more complicated than just a simple convincing people that they need to be vaccinated. And it's part of an international issue, not just a United States issue. And I think all of us in public health and clinical medicine around the world really have a lot to learn. We're at a very, very different time in our history where it used to be if we made a recommendation, public health was, the white coats. They were the people who saved lives, and everyone basically kind of marched to the recommendations. That's not the case anymore. And we have a lot of work to do to understand that and what we can do to change that.
Thank you for that. I think that putting us in the context of the rest of the world is really important in this moment. We are obviously seeing what's happening here in America, but it's important to see what's happening in other countries too. Does anyone else want to comment on maybe impacts on innovation or equity?
Certainly on the innovation side, as you well know, Massachusetts has been one of the leading recipients of NIH funding for years and years. And that is and potentially will be at jeopardy moving forward. I think one of the things that happens with constraint is constraint can often serve as a platform for innovation. And I think one of the things that will need to happen is for partnerships that traditionally haven't occurred to move forward. I think the state with the hospitals, industry, will have to look for newer ways to solve the issues that historically had relied on a revenue stream from the government that may be at risk. I'm hopeful that the government will continue to see the importance of investing in science and in research, and that much of the funding that has been at risk will find a way to return to either current or close to current levels. But in the absence of that, I think one of the things that Massachusetts will offer is the ability to partner in all of these spheres, private, public, the government, and solve problems in a way that will be novel just because of the changes with regards to the federal government.
Yeah, thank you for that. Maybe it'll give me an opportunity to just highlight the work that we are doing here in Massachusetts, in particular at the Department of Public Health, recognizing that we have a pretty sizable population here in Massachusetts. We have a population that has, for the large part, really bought into vaccination and believes in the power of vaccination, as we all do. And we are trying to use that to our advantage and to see, should the federal system fail, could we develop a state-run system that guarantees purchase of vaccines, that drives the industry to continue to innovate, continue to manufacture in particular, but also to continue to innovate in the vaccines that they're developing? And can we get those vaccines out to everyone in Massachusetts? And if we do it here, can we help others across the country do it? And I think we'll see over the coming weeks and months, Massachusetts really trying to drive forward with that and maintain its status as a leader in vaccination in this country, something that we're really proud of. I want to see if there are members of the council who have questions or comments that they want to bring into this. I see Craig with your hand up first.
Thank you, Commissioner, and thank you to the panelists. It was really interesting in hearing all the different perspectives, and I appreciate the comments that were spoken about the change in dynamics in terms of healthcare and public health. We have a long tradition and have gotten comfortable in standing on a rock solid understanding of what the science and what the data tell us, and having strong confidence that our our clients, our patients, our residents understand us and know that we have their best interests at heart. And now we're in a place where we have competition, and to a degree, we're losing the framing game, and our conversations in community are being overrun by people that are, from broad perspectives, much more charismatic, telling better stories, tapping into values, and being able to paint better pictures of comments in ways that bypass the data, bypass the science, and have convinced educated people across identities to think in different ways. More and more people, even in Massachusetts, are more individualistic as opposed to dedicated to community and all of that. And so I wonder how the panelists would speak to the need to be more creative in matching data with values, with storytelling and all of that, to be in community more accessibly, to be able to compete in a new day where disinformation and misinformation are sometimes winning the day, even though the information is clouded in so many different ways.
Sure. All of you might have answers to that. Maybe Dr. Barnett, can we ask you first? From the AAP perspective, I think so much of what you do is to try to get information out and to share what is fact.
Yes, absolutely. And I think you've hit upon one of the critical factors here. And anecdotally, what some of us are hearing is that there are parents who are going to their doctors asking for appointments to accelerate their child's vaccines because they're worried that the current process that has been put in place will end up depriving children of access to immunizations. I think we need to build on that energy by creating messaging that supports vaccines by using trusted messengers and taking into account the many, many different ways people are hesitant about vaccines and trying to address them by using messengers from that community or those backgrounds to really try and connect with the people that we want to connect with. And I think one comment about equity is that some of our newer Americans, those who come from families who are immigrants and those born in the US, are some of the most vulnerable because the situation now that's set up has made many of these families fearful of even accessing healthcare, not just vaccines, but all aspects of healthcare. So I'm very happy to see and hear what's being done here to address these inequities.
I'll add my classic line on trust. I think we all talk about trust quite a bit, and especially throughout the COVID pandemic, we have talked significantly about trust in public health. And I think of trust as the combination of knowledge and empathy. And when we think of trusted messengers, those that can bring knowledge to the conversation, sometimes we have to provide that to them in our education. But very importantly, those that can bring empathy to the conversation, I think is so important in building trust. Dr. Cotton, I'm sure you have thoughts here too.
You know, I just wanted to highlight that there was a really nice MMWR from August 7th, and it was in emergency rooms with underserved populations, and just offering vaccines to people. Almost half of the people said sure they would get the vaccines, and of that half, almost all of them said they would accept all recommended vaccines. So I think sometimes, so that's a pretty good, those are pretty good numbers in an emergency room in an underserved area. Like those are things that we would think might not work so well, but there was an easy half that said they would do it. And I think part of it is that we sometimes don't offer. I know pediatrics offers very readily as part of their regular workflow. But for me, I think we miss the opportunity to even offer adults routine vaccines. And so sometimes just making the bar to vaccine availability as low as possible can be helpful. I also would like to acknowledge that I think some clinicians feel vaccine fatigue. And so maybe understanding the importance of that and finding ways to deal with that on our side could be helpful, just so that we end up making more vaccine recommendations. There might be some low-hanging fruit there. Over.
For that. Stuart, can we go to you?
Sure. Thank you so much. Thank you. Great panel. Appreciate everyone's contributions. This kind of follows up on Craig's point in thinking more about communities and how we impact communities as public health practitioners. Obviously, at the end of the day, you need to have a one-on-one for the person who's getting vaccinated. But if you think about what's happened in Texas and in Alberta in Canada, these are very much influenced by particular communities that, for whatever reason, have created a more resistance to vaccines. And I also want to tie this to what Commissioner Goldstein was saying in Massachusetts with respect to vaccine equity and some of the very successful strategies we've had that really may have worked with particular communities. So that's the question, which is, how do we think about moving communities as well as, as part of the process to ultimately get to better individual decision making?
And this is the conundrum of public health versus individual medicine that we're all grappling with at all times. I'm looking to see that anyone on the panel want to take a first.
Could I just add a comment here? I think that far too often when we present public information around numbers, we use the old approach that if your head's in the freezer and your feet are in the oven and average your temperature is just right. And one of the challenges we have, even in a state like Minnesota, where we have about 92% of our population of kids vaccinated, we have pockets with schools of over 50% or less of the kids are vaccinated. And so we also can't assume that everyone is a child is the same as another child is the same as another child. And I think this is where equity becomes a real challenge, because in many cases, these under-vaccinated areas also are very much a part of the equity issue. And so one of the problems we have is that we want to continue to reinforce and surely keep up the good numbers in those places where we have them. But how do we bring up those very large dropped areas of vaccination? And I think that's a real challenge. So I'm going a little uncomfortable whenever I see the data presented for all 50 states, because what I'm trying to figure out is how hot is it in the oven with your head, and how cold is it in the freezer with your feet? And what does that mean?
I think it's a great point. And what we like to champion Massachusetts as a leader in vaccination, pediatric vaccination. We too have pockets of the state that are far below our average.
Yeah.
I don't think they're as low as some other areas of the country, but certainly we have areas of rural Massachusetts out in Western Mass, parts of some of our urban areas, the Cape and the Islands in particular, that have fairly low vaccination rates. And the single average does not give the whole picture. I will use this maybe as an opportunity to highlight the Vaccine Equity Initiative and the work we did with COVID, which really tried to address that particular point, to recognize there are parts of the state that have had vaccine hesitancy for decades, and they were not accepting the COVID vaccine. And so we made a concerted effort to go out into those communities, some of which were very rural, some of which were urban, some of which were suburban, and to, as Dr. Barnett mentioned earlier, bring with us trusted messengers and the vaccine, and continue to knock on the door. We didn't take no for an answer. We just kept going back. And it paid dividends, because when it came time for the booster dose, folks were ready to have the same person knock on their door, and they were willing to accept that vaccine. And I am hopeful that we will see long-term dividends in this, that rates of childhood vaccination will increase, that we'll have persistent, continued high rates of COVID and flu vaccine in those communities. But it takes energy, it takes a lot of effort to do that work.
Commissioner Goldstein, you're absolutely right. And during the COVID time, I think outreach to community leaders was absolutely critical. Sometimes I think when someone is shouting as loud as possible from the soapbox, the way to get the message through is to have the quieter conversation on the side. And I think it's just a lot of, unfortunately, effort that will be required to get out to all the corners of the state to make sure everybody hears the importance of this message.
Dr. Subbaraman, maybe we'll go to you. We could have had you on this panel too, I'm sure.
Really amazing discussion. I have a couple of questions, if it's okay. The first is really, first of all, I think it's really sort of wise with the rapid change in the ACIP and the potential for, recommendations that may not fully align with evidence around vaccine that might emerge, to have a parallel sort of state infrastructure, parallel infrastructure of evidence among professional societies, what Dr. Osterholm talked about with their attempts to sort of, essentially curate evidence. But as part of that, so first of all, I think that's absolutely necessary. I also could imagine situations where you have different types of communication coming from different parts of the country, and that could sow a much broader sense of distrust. So I guess one question I have is, are there ways that there could be cross-state DPH communication of recommendations to sort of create broader confidence, because there will now be potentially competing recommendations from states, professional societies, and the federal government. So that's sort of one question, and I think it could be a very, very broad challenge in the next 3 years. The second one is really around uptake, and this maybe goes to Dr. Cotton's point about sometimes maybe we're not offering as aggressively as we should for people who might just say, yeah, sure. With the healthcare provider data, are there ways that health systems could move to opt-out strategies where maybe you're scheduled a date to get your COVID and flu vaccine for the season, rather than sort of providers having to navigate the decision about when and how to schedule it themselves, even in settings where the hospitals or healthcare settings are actually providing it, in the hospital. Even then, sometimes it's hard to sort of, make the decision to do it. So anyways, those are sort of two questions I had. Thank you.
Both great questions. And we'll start with the first one about the sort of competing recommendations. I can give you my perspective as a state health officer representing Massachusetts, and conversations that I've had with our neighboring states and with states across the country. I too am incredibly worried about individual states coming out with recommendations, because even if those recommendations are fully based in science, the fact that they're coming out differently from different states is going to infuse the pretense of politicization into the recommendation process. And so I've really encouraged the other state health officers, in particular in the Northeast, but anyone who will listen, to look to the national bodies. And we have two represented on this call here, and I'll let them respond. One being the Vaccine Integrity Project and the work that Dr. Osterholm described of collecting data, and the other being the professional societies. And I'll turn to Dr. Barnett to talk about AAP and that recommendation process. But I think if we as states can point to a national organization that has done their due diligence, and then all bring that back, and of course we'll translate it to what it means for people in Massachusetts. We use different words here, right? It's okay for us to tweak the language a little bit, but it's not okay for us to each have a different recommendation. Dr. Barnett, Dr. Osterholm, I don't know who wants to maybe start and talk about that.
Well, I can just mention something about the American Academy of Pediatrics, and they were a liaison organization to the ACIP, and liaison organizations received a communication also basically firing us because we were felt to have a bias because we represented an organization. We were not representing our own individual opinions. I think what is missing from the relationship of the liaison organizations to the ACIP was that these organizations, the AAP in particular, worked very hard to make sure that the recommendations that would come out in their reports and the Red Book were harmonized with the ACIP recommendations. And this often involved a process of several meetings and resulted in staving off what you just described as confusion resulting from multiple different recommendations. So I think the AAP is working very hard with the Infectious Disease Society of America, Maternal Fetal Medicine, American Public Health Association, the American College of Physicians, in order to harmonize recommendations and provide that to their states and other public health officials to help avoid what confusion you just described.
Dr. Ostrom?
Yeah, I would just say, I would second that. First of all, just to remind everyone, we are not making recommendations from the Vaccine Integrity Project. We are merely doing the work of pulling all this information together. And I might add, just to give you an idea of this, the data that we've collected and analyzed is since the last ACIP review of either COVID, RSV, or influenza. So we still have identified 150 randomized controlled trials that were done since that time that address these vaccines that has not yet been summarized in the public. So there's a lot of really good information there. We have worked closely with the societies that have traditionally made recommendations in the past, and so I would expect that they would continue to do that again. But as Dr. Barnett just said, they were based largely on what the ACIP had come up with, though they don't have that now. And so what we're trying to do is basically help assist the societies to come up with their recommendations in the absence of ACIP, but with as much harmonization as possible. And I think, Dr. Goldstein, your leadership on a national level has been very important in trying to emphasize the importance of harmonization. We have heard from the payers over and over again, the fewer number of recommendations for a given vaccine that we can get will only make our job easier in terms of trying to cover them. And the discussion, Shirley, and I don't want to pretend to be the expert on this, but, is the ACIP really just the basement, not the ceiling of what recommendations can be? Can we use other alternative sources? And I think that's, again, where we want to see harmonization as much as we can, just to make the payers in a better place to be able to, come through and cover these vaccines.
Maybe for your second question, I'll turn to Dr. Chang and Dr. Cotton about this concept of opt-out. It works in HIV testing. I know that from experience. Would it work in vaccination?
Yeah, again, the AAP has done a lot of work on this around vaccine hesitancy, and we talk about a presumptive approach when somebody comes in and for a visit, and we presume that they are getting vaccines, and even the language we use in terms of just discussing the flow of the appointment, and to say your child will be receiving these vaccines today. Really, that subtle difference between asking permission and sort of presuming that it's going to happen can move the needle on an individual who may be on the fence, and so it definitely works. And AAP is a whole sort of guidelines and suggested language to put this into place, and it can make a real difference in the real life one-on-one setting.
Dr. Cotton, any additional thoughts?
I think I would sort of be in favor of opt-out, but I do think there would be a lot of potential issues around that. Again, I think I actually think it probably would be time to really talk with patients just about merits of vaccination. I worry that there could be some ramifications if there were to be sort of an opt-out situation, but worth considering.
All right, maybe we will move on. I'm cognizant of time, and I want to first be incredibly grateful for our panelists for spending this time with us. And I hope they'll be patient with us. We have a couple more questions from the council. We'll go to Tom.
They're great. I'm wonderful to have this council with us, and just want to appreciate your expertise in being with us today and sharing it. My question, Dr. Chiang had mentioned this opportunity for constraint to often foster innovation. And that we may be in such a circumstance, and I think that that's a really wise way to kind of look at it, glass half full. I think one of the challenges can be when there is these types of innovations is the learning across them, having the infrastructure and the strategies in place to facilitate learning, for example, across state systems. And I'm just curious if we could spend a little time, I'd love to hear about what might be in place to facilitate that learning in light of the innovation that is occurring, and to ensure that best practices emerging in this uncertain and changing context are highlighted and shared as best as can be possible between states and healthcare systems.
A really good question. It's a system that I'm not sure is in place, but needs to be built in this moment. I'm speaking sort of from the role of a state health officer here. That system came to us through CDC. That's who gave us best practices for immunization. That's who made sure that State departments of public health could pass along information to municipal departments of public health and to healthcare settings. And at this moment, we can't always look to CDC for the guidance that we had received previously. I do think there are networks that exist. The Association for State and Territorial Health Officers, ASTO, is a trade organization that holds us all together. Here in the Northeast, we have been speaking frequently and collaboratively about how to synergize on our approach, thinking about messaging, thinking about immunization infrastructure. But I think this is a little bit of building the plane while we fly it, because we have not had to do this before. I don't know, Mike, you were also a state health officer, correct?
Yeah. Well, you know, I look at this situation now, and let me just, if I could paint an innovation challenge. First of all, I feel that this is an important issue because Boston has been a center for innovation around these vaccines. And if you look at some of the big losses of resources recently, Boston has been hit inordinately hard. But just think of the following scenario. Right now, if we were to have a significant influenza pandemic, of which we could have one tomorrow that could be much worse than we saw with COVID, the global capacity to make influenza vaccine with inbreeded chicken eggs, which is what our 50-some-year-old process is, we could vaccinate about a quarter of the world's population in 18 months once the pandemic began with that process. On the other hand, with an mRNA technology and what we do know, and we still have a lot of work to do on that, we could probably vaccinate the whole world in the first 8 to 10 months, just based on the ability to manufacture the vaccine. And clearly, we believe it would be every bit as efficacious. We've taken all of that incentive money for innovation away. One day I worry we're going to wake up and we're going to find ourselves in an influenza pandemic and say, oh my God, how did we get here? And for those countries around the world that are going to pursue this, they'll be at the head of the line. We'll be at the back of the line. So I think we have to continue also as a medical community to not only talk about innovation at the individual patient level, which is critical, don't want to minimize, but we've got to look at these big picture issues also and why we need those resources to go to the researchers in Boston who are doing some of this really innovative vaccine work that frankly would pay huge dividends if we ever saw a pandemic of influenza in the near term. So I don't want to get in a soapbox with this, but I think you all happen to be at ground zero where some of the most important research has been ongoing and has been withdrawn.
Yeah, I would just riff on this just 1 second, and to Commissioner Goldstein's point, we've lost the major repository for all of this data was held. And the truth is an elusive object, and the only way you get to the truth is by compiling just tons and tons of data. And so whatever happens moving forward, we have to figure out how to come up with that infrastructure to be able to record literally at that level of who gets vaccines, what happens in the future. And unfortunately, right now, the nation's repository has chosen a different priority with regards to what it wants to do moving forward. And so that is one thing that I think we need to problem solve for, certainly within the state. But to get to the big picture is between states and ultimately the country as a whole.
Craig?
Thank you. I just want to return to what Dr. Chang and Dr. Osterholm had brought up early in this conversation. How do we, one, acknowledge that we have identities that are dynamically changed and shifting as we go through this new administration? There is no doubt that there was an agenda to create confusion. So how do we find ways to make sure that we can listen actively with our clients and patients in all kinds of different ways? And then on the other side, acknowledge that the opposition, as I would call it, took decades to build a Project 2025. And how do we make sure that we can have a Project 2029 in a way that rebuilds the structures that are being teared down in a way that involves a coordinated effort that builds trust across dynamics, brings down silos. So, the idea that we would have partners in that active listening with community health workers, social workers, and all kinds of others, but also make sure that we're acting now to develop coordinated institutes and organizations that are building a strategy to rebuild and to integrate the ways that we know work. We can't just treat the progressive part of our patient profile. We have to care for everyone. And how can we do that on both sides? Active listening, engaging in community, but also structures that are ready to step in right away to rebuild and to kind of build the confidence that we're losing on an ongoing basis.
If anyone from the panel wants to respond to that, it reminds me of something I learned, I think, in high school chemistry, which is the world tends towards entropy. It's much easier to fall into confusion than it is to build something up. But I don't know if anyone on the panel has.
Well, let me just say again, I think there's creative activities out there that actually can address this. And what I mean by that is there's a group of over 60 philanthropic organizations that have come together under what's called FAST, led by the Doris Duke Foundation. And they are all trying to figure out how they best invest their money in what's happening right now. And there's a major issue around a science pillar. And I have been co-chairing that as an advisory. And I see really remarkable resources that are available right now, but people are trying to figure out how do we build this 2029 approach, just as you just said. What do we do? And I think this is where we need to be creative. You know, we're not going to get it from the federal government, but I think there's some incredible opportunities. Our center is a good example of how philanthropic support can help support a lot of these kinds of things we're talking about today. And they're just looking for the way to do it. And so I think we want to be engaged with them as much as we can to put ourselves in a position to receive those funds to do the work that we're talking about.
Dr. Archer, maybe we'll give you the last question.
Thanks so much. I just want to share my appreciation for the panel and also for the commissioner in, continuing to give hope to the people of this Commonwealth and hopefully the entire nation that we're going to lean into a crisis and be innovative and figure something out. I also represent community health centers across the state. I work at a rural health center out on the Outer Cape, and I am reminded constantly about how access to primary care and vaccines are so intimately connected, but also in the prevention and the provision of care for all chronic disease. And I wonder if there's a part of this innovation that you're going to do, Commissioner, in the state that recognizes how you often start our meetings talking about the history of how amazing Massachusetts has been as a leader in the world around solving problems related to our health. And if this is one of those times that we need to think about what allows us to continue to be hyper-focused on our communities in the Commonwealth, are there ways that we can provide support to community health centers, not to disappear, but to expand their care? Which is primary care focus, which is prevention. Do we need something like state qualified health centers that mimic what the federal government has done to provide the ability for us to give care to people regardless of their ability to pay? Because we automatically are the intersection of equity and medical services, and primary care is the center of what we focus on. So again, I just want to thank you all for providing the space. And I want to encourage the continued innovation and the thoughts of making Massachusetts strong and independent. Because when there's not alignment in relationships, sometimes you have to focus on yourself and figure it out.
Thanks, Dr. Archer. And I will, as you note, and this council is well aware, I'm a big fan of our history here in Massachusetts. I will probably anger a state down south, but one could say we are the birthplace of community health centers. Some might disagree with that, but I think here in Massachusetts, we have the first community health center, and it's an important part, a rich part of our history, that promotion of primary care and prevention. With that, I'm gonna give incredible gratitude to our panel for joining us, for staying so long with us, for bringing your expertise, and for leading this fight for us here in Massachusetts and around this country to make sure that we have the right system in place to make recommendations for vaccination, that we've built trust with our communities and our patients, that we're bringing our whole selves to these conversations. So thank you, Dr. Osterholm, Dr. Chang, Dr. Barnett, Dr. Cotton, for all that you're doing and for being here with us for this past hour. We are, that is going to bring us actually to the end of our Public Health Council meeting. I'll thank everyone for their patience in sticking with us through this full meeting. I think it was worthwhile. I'm going to remind everyone that our next meeting is Wednesday, September 10th at 9 a.m. And I'll ask from the council members if there's a motion to adjourn.
So moved.
Thank you, Craig. And is there a second?
Second.
Thank you, Robert. I will now go through the roll call. Craig Andre.
Yes.
Dr. Archer.
Yes.
Lisette Blondette. Kathleen Carey.
Yes.
Emily Cooper. Robert Engel.
Yes.
Marcia Hams. Stuart Landers.
Yes.
Tom Mackey.
Yes.
Mary Moscato. Dr. Stinson.
Yes.
Dr. Subbaraman.
Yes.
Dr. Votoro. And Arya Zayas.
Yes.
And I will vote yes as well. And with that, the meeting is adjourned. Thank you all for being here this month.
Thank you for a
Enjoy the rest of
tremendous
your summer.
program.